Hi, everybody. So, good evening. I hope you're all ready for the session. Okay, so as we did yesterday, although this session is shorter than yesterday's, hopefully it is going to be a little shorter. We're going to cover the important points in gynae. Yesterday we did OBS. I put my number on the chat box. If you have any doubts, ask there because I'm not going to open the chat box. This is the last time I am looking. Everybody is saying good evening. Hi, good evening. Hopefully it will be an amazing session and that will translate into you doing well in the exam. Okay. So that's what we have to keep in mind with hardly 9 days left. What are the important things we need to know? Okay, so let's start with abnormal uterine bleeding. Now, for knowing what is abnormal, we should know what is normal. And remember, there's been a slight change in 2020. The Federation of International Gynecologists and Obstetricians Association made a few changes. So, what is in white, you should know. That is the normal. जो white में है वो normal है. Okay, so the normal menstrual cycle is 24 to 38 days. Earlier, it was 21 to 35 days. So there's been a slight change. Okay. Also, the duration of flow is the normal is up to 8 days. Earlier, it was 2 to 7 days was the normal duration. So now there's no lower limit, and the upper limit has said up till 8 days. The third thing is to define a regular cycle, whether it's irregular or regular, is now you have to see the difference between the shortest to the longest menstrual cycle. Okay, and if that difference is less than or equal to 9 days, it is a regular cycle. ये पहले कभी कहीं पे define नहीं था. How do you say it is regular? But now we know how we say it's regular. If the shortest cycle, say she comes and she says 6 months, say my cycles are irregular. So from the shortest cycle to the longest cycle, if the duration is less than equal to 9 days, it is a regular cycle. And normal flow. So we used to say earlier that more than 80 ml is heavy bleeding. Now it is patient determined. Okay, so the patient will tell you, doctor, I'm changing 3 pads per day. That might be normal for you, but it might be abnormal for her. Maybe she was changing just a pad earlier. So normal is just, there's no definition now, just patient determined. Okay, so important take home from here is this one, mainly this one. Okay, the normal cycle is between 24 to 38-day cycles. Now, abnormal uterine bleeding is any deviation from the normal, all the ones in gray. Okay, all come under abnormal bleeding. And what are the causes of abnormal uterine bleeding? You can divide them as structural causes, which is PALM, and non-structural, which is coin. Okay, so PALM is basically polyp, adeno. It's written here. I'm just writing it again so you get a quick revision. Leiomyoma. Leiomyomas are what? Leiomyomas are fibroid. Okay, and malignancy and pre-malignancy. Hyperplasia means pre-malignancy, like endometrial hyperplasia, and then endometrial cancer. Okay, so this is structural. Non-structural is coagulopathy, then ovulatory dysfunction, then endometrial, then iatrogenic, and not yet classified. That means there is no definition right now. So something like a AV malformation or something which we don't have a separate classification for, all goes here. Okay. Iatrogenic means a woman is, say, on the copper T or she's taking an anticoagulant, warfarin, and she's bleeding heavily. Okay, endometrial basically means a pelvic inflammatory disease, an infection in the endometrium. Okay, ovulatory dysfunction would be something like PCOS. Okay, so this is abnormal uterine bleeding classification. It's very important to know PALM and COIN and what they stand for. And that PALM is structural causes and COIN is non-structural causes. Next, coming to adenomyosis. Adenomyosis, what are the important things? You should be able to identify this picture. This is an enlarged globular uterus. Okay. So what is adenomyosis? It is basically endometriotic implants in the myometrium. And how does the endometrium reach the myometrium? One of the hypotheses is that during delivery, some endometrial glands go inside the myometrium. So that's why these women are Paris women. Remember, if your clinical question says a Paris lady with menorrhagia plus minus, or I won't say plus minus, I would say and or dysmenorrhea. These are the two most common symptoms. Menorrhagia, that means heavy bleeding, okay, in a regular cycle, and dysmenorrhea means painful periods. In a Paris woman, okay, always think of adenomyosis. Okay, because iska jo dusra differential diagnosis hoga, fibroid. Fibroid is going to present usually with the same symptoms, but one of the clues is she may be nulliparous. Okay. Whereas parity, and especially in the age group of 40 to 45 years, this is the common age group. So this is when you get this sort of scenario, menorrhagia, dysmenorrhea, this age group, Paris lady, always think of adenomyosis. And what will you see on this clinical picture? Enlarged globular uterus. So uterus is regularly enlarged. Fibroids will be irregularly enlarged. And adenomyosis will be regularly enlarged. Okay. Now, remember the investigation of choice. So you may get a clinical scenario with this, and they may ask you, what is the investigation of choice for this condition? The answer is a transvaginal sonography. Okay, on a transvaginal sonography, you're going to see a few important things that maybe are a little bit important, are asymmetrical enlargement of the myometrium. Okay, that means the uterus looks like this. The posterior myometrium is more bulky than the anterior myometrium usually. And secondly, the junctional zone. What is the junctional zone? The zone between the endometrium and the myometrium is ill-defined. It is not clear. It's irregular. Okay, so you're not sure where the endometrium is, where the myometrium is. It all appears very blurred. Okay, that is what you see on TVS. And MRI is helpful in doubtful cases. But remember, a TVS is the investigation of choice. What do you do? What is the definitive treatment? So definitive treatment is, of course, a hysterectomy. There's no medicine which is going to reverse the condition. Okay, whatever glands have gone in the myometrium, they will continue to grow there. But so definitive treatment is to remove the uterus. But you can give a lot of medicines. So medical management for symptomatic relief can be given. Okay. And this includes NSAIDs if she's having severe dysmenorrhea, antifibrinolytics like tranexamic acid. Okay. Then you can give combined OC pills. This will reduce the bleeding and the pain. Then you can give only progesterones. Okay. And this is usually given in the form of Mirena. What is Mirena? It is a levonorgestrel intrauterine device. Okay. So these are some of the drugs that are usually given. Next important topic is fibroids. Now, this is multiple fibroids, so it gives an irregularly enlarged appearance. Important points in fibroid, remember, fibroid is a hyperestrogenic state. That means the more the amount of estrogen in the body, the more the fibroids will grow. Okay, what are the other hyperestrogenic states? Endometrial hyperplasia, endometrial carcinoma, endometriosis. Okay, so all the endo ones, these are all hyperplasia, endometrial or hyperestrogenic states. Okay, and of course this one, so fibroid uterus. These are all hyperestrogenic states and they usually coexist with each other. So fibroid, commonly you'll find endometriosis. Fibroid, you'll commonly find endometrial hyperplasia and even malignancy. Okay, apart from these two, it's very important to know that it is associated with hyperestrogenic states. Okay. Now, the typical clinical feature, I've told you again, is usually a nulliparous or a woman with low parity. Just a second. Okay, I'm really sorry. Okay, so nulliparous or low parity with menorrhagia or dysmenorrhea. Okay, so this is the typical. So remember, the parity is going to be different. Adenomyosis paris and fibroid uterus would be nulliparous or low parity. Okay, now types of fibroids. So we know the basic classification is that this is a submucous fibroid. Okay, this is an intramural fibroid. Okay, and this is a subserous fibroid. This is the basic classification. Okay, if you want to go in a little more detail, you can further classify this is the uterus. Okay, and this is the more complicated classification. I'll just quickly go through it once with all of you. So this is a type 0 fibroid. Okay, this is a type 1 fibroid. Okay, and this is a type 2 fibroid. Okay, so this is basically three types of submucosal fibroid: 0, 1, and 2. 0 क्या है? 0 है completely pedunculated inside the cavity. 1 is where more than 50% is in the cavity. 2 is where more than 50% is in the myometrium. Then you have 3, okay, 4, okay, 5. 5, I'll draw again. 5, 6, and 7. Okay, so 3, 4, 5, 6, and 7. So, but the new classification says you just have two types of fibroids, submucosal and others. Submucosal are your 0, 1, and 2, and others are your 3, 4, 5, 6, 7, and 8. Okay, what are 3, 4, 5, 6, 7? 3 is it's just touching the endometrium, but it's mostly intramural. 4 is completely intramural. 5 is more than 50% intramural. 6 is more than 50% subserous. And 7 is pedunculated subserous. Okay, so these all come under O. And 8 kya hai? 8 is a cervical fibroid or a broad ligament fibroid. Okay, that means it's in a different place. So cervical or broad ligament. Okay, so these are the complete classification of types of fibroid. If you want to know this has never been asked, but it's something new, so you never know. But this you should know. The subserous kya hai, intramuscular kya hai, and submucosal kya hai. This is a must know. Everybody has to know this. Okay. Now remember that these two, another thing important, the type 0 and the type 1. That means ये वाला जो मैं purple में कर रही हूँ, this one and this one. Okay, the type 0 and the type 1 can be removed hysteroscopically. That means if I put a hysteroscope inside from here, Okay, I can remove these two fibroids. All the rest, all the other ones have to be removed laparoscopically or by laparotomy if you're removing the fibroid. Okay, only a type 0 and a type 1 can you remove from inside the uterus. Okay. Now, the most common degeneration, so fibroids are prone to undergo degeneration. The most common type of degeneration is a hyaline degeneration. This is the most common. Okay. And the second important one you have to remember is the red degeneration. Okay, the red degeneration looks like this, okay, but it is not commonly a reason why we do hysterectomy because red degeneration happens in pregnancy. Okay, it happens usually in the second trimester of pregnancy. It can also happen postpartum. It can also happen on a woman taking contraceptive pills. What is the typical presentation? A woman who is a known case of fibroid uterus. That's how your question will be. Or they may not give that she's a known case of fibroid. The typical presentation will be acute abdominal pain in the second trimester of pregnancy. There may be fever. Okay, so fever is plus minus. It is not necessary in every patient. And there may be a raised total count, but this is not an infective process. Remember, it doesn't mean there's an infection. Okay, and again, they are plus minus. What do you do? The question that is asked is either what is your diagnosis, and the second question they ask is what is the treatment? Remember, for a red degeneration, you will never terminate the pregnancy. Neither will you do a hysterectomy. So what will you not do? Because the question will tempt you to do it, but you won't do it. You won't do an MTP. You won't do a hysterectomy. What will you do then? You will continue the pregnancy, okay, and just conservatively manage her. You will give her analgesics, you will hydrate her, okay, and you will make her comfortable. बस कुछ नहीं करना और ठीक है अपने आप ही the pain will settle down. Okay, 99.9% patients the pain will settle down. Okay, so this is what is the treatment. The examiners are going to try and trick you and say कि patient has come with acute pain, not settling. What will you do? It will settle down. Okay, so there's no hurry to terminate the pregnancy. The third one you should know, the third degeneration, which is sometimes asked, is a leiomyosarcoma. So remember, leiomyomas, fibroids are benign. Fibroids are benign in 99.999% women, but 0.01% risk of sarcomatous change is there. That is called a sarcomatous degeneration, a malignant degeneration. Okay, that is in hardly 0.01% cases. Okay, so these are the degenerations. Clinical features, they could be completely asymptomatic or they could have very commonly menorrhagia, that means heavy bleeding in a regular cycle. Question that comes is why is there menorrhagia? Menorrhagia, why? Because number one, there is increased surface area of the endometrium. So more endometrium will be shed. See this is an extra surface area. This is extra surface area. Okay, secondly, there is the contractions are hampered. So normally the bleeding stops in periods because of the uterus contracting. Here contractions are hampered. That means they're irregular. Okay, also there is in general increased vascularity in the uterus because all these fibroids have their blood supply. तो वैसे uterus बहुत vascular हो जाता है. And fourthly, there may be associated endometrial hyperplasia or endometrial CA. This endometrium may otherwise be hyperplastic because she is an endometriotic, she has hyperestrogenism. Okay, so there is a higher risk of these things in the endometrium. Okay, so this is menstrual abnormalities. But suppose this is there. What is this? What kind of fibroid is this? This looks like a type 0 fibroid because this is a hysteroscopic. This can come as an image-based question. This is a hysteroscopic view of the uterus where you are seeing a submucosal fibroid. Okay, so this is inside the uterus. In anything inside the uterus, you are seeing is a hysteroscopy. Anything from outside the uterus is a laparoscopy. So this is a submucosal fibroid. Okay, so how will this kind of fibroid present clinically? It may not cause menorrhagia. This may actually cause what is called as intermenstrual bleeding. That means the patient will have bleeding in between her periods, and she can also have severe dysmenorrhea because the uterus is trying to expel this out. ये जो surface है इसका ये erode हो जाएगा, infect हो सकता है, and that's why she can have intermenstrual bleeding. So she may not have heavy menstrual bleeding. She is more likely to have intermenstrual bleeding, bleeding in between her periods, along with dysmenorrhea. Okay, but most patients will have menorrhagia. Okay, dysmenorrhea is the second common symptom, and it causes congestive dysmenorrhea. Okay, not spasmodic dysmenorrhea. Spasmodic dysmenorrhea is the normal wala dysmenorrhea. Congestive dysmenorrhea is usually because of a pathology, okay, like fibroids, like adenomyosis, like endometriosis. All right. Second important symptom which you should know apart from menstrual complaints and dysmenorrhea is subfertility or infertility. So fibroids are known to cause infertility, especially if they are submucosal. They are right inside the cavity, तो वो embryo को implant नहीं होने देते हैं. And secondly, if they are large intramural fibroids distorting the uterine cavity. And when I say large, I mean usually more than 5 centimeters. So any of these two kinds of fibroids you find in a woman who is having infertility, these are likely to be the cause. So you should remove them. So a myomectomy should be done. Myomectomy means removing the fibroid. The surgery called to remove the fibroid. Only the fibroid is called a myomectomy. So a myomectomy should be done if you find a submucosal fibroid or if you find large इंट्राम्यूरल फाइब्रॉइड्स विच आर डिस्टॉर्टिंग द यूट्राइन कैविटी. अगर आपके पास क्वेश्चन आता है कि पेशेंट हैज इनफर्टिलिटी एंड ऑन अल्ट्रासाउंड यू फाइंड अ सबसीरस फाइब्रॉइड, what should you do? The answer is don't do anything for her, as in at least don't do a surgical myomectomy for her, okay? Because this fibroid is not going to interfere with fertility. What is going to interfere with fertility is something sitting here or something which is large, which is going to distort the cavity. That means something which is going to hamper her implantation. So indications for myomectomy in an infertile patient are any submucosal fibroid, even it's very tiny, you have to remove it, and any large intramural fibroid which is distorting the cavity. Okay. Then the fibroid can actually present as an abdominal mass. Many times we have women coming to us with no other symptom except a large abdominal mass. Okay. And because of a large abdominal mass, she may actually have pressure symptoms. So if it's an anterior fibroid, she may have urinary symptoms. She may have retention of urine frequency, okay, and she may even have constipation if it is a large posterior fibroid. Okay, so urinary complaints if it's anterior and rectal complaints if it is a posterior fibroid. Okay, it can also affect a pregnancy. So remember, there are two things you should remember. One is what happens to the fibroid in pregnancy. And second question is what happens to the pregnancy in a fibroid. Okay, इसका आंसर हम पढ़ चुके हैं. What happens through the fibroid in pregnancy? It undergoes red degeneration. Okay, and what happens to the pregnancy in fibroid? So fibroid in pregnancy, if you go back to yesterday's obstetrics, increases the risk of miscarriage or abortions. Okay, it causes preterm labor. Okay, it can cause prolonged labor. It can cause malpresentations like breech or transverse lie. It can cause, because it's causing irregular contractions, it's not allowing the uterus to contract, prolonged labor. At the same time, it can also cause postpartum hemorrhage or even a retained placenta, okay, because of inefficient uterine contractions in the postpartum period. Okay, so this happens to the pregnancy because of fibroid, and red degeneration is happening to the fibroid because of pregnancy. Okay. What will you do if it's asymptomatic? This comes as a question. So no treatment is required, okay, except a yearly ultrasound to see the size, whether it's increasing in size, okay. So incidentally detected fibroid on ultrasound with no symptoms does not require treatment, even if it's very, very big. You may ask me how big. So the earlier thinking was if it's more than 14-week size of a gravid uterus, that then you should remove it. मतलब अगर abdominally palpable है तो उसको निकाल देना चाहिए, है ना. But the new thinking is कि no, let it be, okay, because they are benign tumors. Surgery is not going to is not indicated, okay, unless it's causing symptoms. But usually itna bada fibroid equivalent to a third 3 months of pregnancy is going to cause some pressure symptoms, okay. So unless she has any symptoms, don't do anything. Just a yearly ultrasound is required, okay. Symptomatic fibroids, you can manage them depending on the symptoms, okay. So it depends on a lot of things. The management depends on the age of the patient, the severity of symptoms, the size of the fibroid, and the location of fibroid. I told you, na, how do we remove a type 0 and 1? A hysteroscopy. बाकी सबके लिए laparoscopy. ठीक है, but जरूरी नहीं है कि सबको surgery करना है, ठीक है. You can also manage them medically. So everything depends on the question, the way it is asked. Okay, I told you already, for an infertile patient, you have to do a myomectomy, that is surgical management. And if it's type 0 or 1, you remove it hysteroscopically. All the others, you remove them laparoscopically or laparotomy. But again, सबका नहीं निकालते, किनका निकालते? Only if she has a submucosal fibroid or an intramural fibroid, which is very large, more than 5 centimeters. Okay. These are the drugs you can use for medical management of fibroid. Tranexamic acid, just quick brief go through of this. It is only used for symptomatic purposes. Okay. Mifepristone, or where else do we read about mifepristone? We use it along with misoprostol in first and second trimester abortions, right? In MTP. So it is an anti-progesterone or a SPRM. It's the same thing, anti-progesterone. It also comes under the category of selective progesterone receptor modulator. दोनों ठीक है, because it has more of anti-progesterogenic action. This reduces the size of the fibroid and the symptoms. Okay. The side effect is it can cause endometrial hyperplasia. GnRH agonist, what should you remember about this? This reduces the size and bleeding both, okay? And very important, if you're giving GnRH for a long time, you should always give add-back therapy. GnRH kya karega? GnRH karega hypoestrogenism. Okay, it's going to suppress the estrogen levels, okay? And this over a long time leads to a pseudo-menopause-like state where there will be increased bone loss. Okay, so you have to give add back therapy. Add back therapy का मतलब है आप estrogen अलग से patient को दोगे in the form of OC pills, or you can give her bisphosphonates or some therapy where there is no bone, where the bone loss gets the bone loss is not that severe. Okay, so add back therapy should be given if you're giving long-term GnRH agonist. Then you can give OC pills. OC pills will just reduce the bleeding, not the size of the fibroid. Danazol पहले देते थे, अब नहीं देते हैं because of the very bad side effects. All the androgenic side effects. It's not given anymore. It is an anti-gonadotropin. ओके, गोनाडोट्रोपिन क्या होता है? FSH-LH, मतलब FSH-LH को कम कर देता है, तो ईस्ट्रोजन भी कम हो जाता है. So all these GnRH agonist, danazol, how are they acting? Even combined ECP, they are lowering the levels of estrogen in the body. LNG is Mirena. Remember, Mirena can be put, adenomyosis में भी हमने दिया, यहाँ पे भी देते हैं, but only if the fibroid is not distorting the cavity. अगर fibroid is distorting the cavity, you can't use the Mirena. Mirena acts by, we will study about Mirena in detail in contraception. It causes endometrial atrophy. This is very, very important. Remember this word. जहाँ पे भी आप progesterone दे रहे हो, you're causing endometrial atrophy. So remember this thing, that progesterone is anywhere you give it, it's going to cause endometrial atrophy. Okay. Now, surgical, we have two things. Either we do a myomectomy or we do a hysterectomy, depending on the age and the want for having further children, or children or further children. So if she's young and wants children, then we usually do a myomectomy. That means we just remove the fibroid. I told you type 0 and type 1 by hysteroscopy, and all the others by laparoscopy abdominally, or laparoscopy or laparotomy. Okay? And hysterectomy is removing the complete uterus. Okay? There are some newer management options which you should at least know the names of. One is MR guided focused ultrasound. So MR is through an MRI machine, focused ultrasound waves are given. Okay, and this is a non-invasive technique. Okay, to shrink the fibroid, but it is done only in women who don't want to conceive. It is not recommended in women who are seeking fertility. Okay, so that's very important. A uterine artery embolization is what? Here you can see this is the uterine artery. Again, it's a non-invasive technique, and microparticles are basically passed through this catheter, which is in the uterine artery, and this reduces the blood supply of the fibroid. Again, not recommended in women who want to conceive. Okay, because you're basically cutting off the blood supply of the uterus. It has been found that women who conceive after this, they have a higher incidence of abortions, of preeclampsia, of preterm labor, of IUGR, of abruption, because of less blood supply to the uterus. So not recommended in women who want to conceive, number one. Okay, and it can also be used. So UAE, where all have we read? We can use it in PPH, but only in patients who are hemodynamically stable. We can use it in fibroid. We can use it in adenomyosis also. Okay, we can use it in patients who have uterine, or I'll write it like this, AV malformations, arteriovenous malformations of the uterus, which is a very rare entity, but it is a very common procedure done for this rare entity. Okay, so this is what you should remember about uterine artery embolization. और क्या याद रखना है? Uterine artery is a branch of the internal iliac artery, which is which division? The anterior division. So basically, what is happening? The aorta is dividing into two common iliacs. The common iliacs are dividing into an external iliac and an internal iliac. ठीक है, external iliac continues as the femoral. Okay, and internal iliac gives off an anterior division and a posterior division. Anterior division का branch है uterine artery. तो जब हम UAE करते हैं, हम कैसे जाते हैं? हम femoral artery के through जाते हैं, यहाँ तक आते हैं और फिर यहाँ जाते हैं. That's how this catheter has actually reached here, through the femoral artery. Okay, so that's important to know. Okay. Now, coming to the next very, very important but very small topic is endometriosis. इसमें क्या क्या important है? Endometriosis, you should know, is endometriotic implants outside the uterus. तो inside the uterus को हम कहते हैं adenomyosis, outside the uterus को कहते हैं endometriosis. So what's basically happening is this is the uterus. Okay, and for some reason the exact cause is not known. The most common hypothesis is कि when menstrual blood comes out, some menstrual blood is going through the tube. Okay, and those endometriotic glands are coming and spilling into the peritoneum and collecting here. So what happens is collection of blood keeps happening. The most common site is the ovary. So ovary is the most common site, and this collection of blood will eventually form a chocolate cyst. Because of this retrograde menstruation hypothesis, one of the common questions that come is that you should know is an obstructive Mullerian anomaly. कहीं पे भी obstruction है, for example an imperforate hymen, a transverse vaginal septum, cervical agenesis, vaginal agenesis, what's going to happen? Blood is going to collect here and then backwards until she develops endometriosis. Okay, so most common site is the ovary. Other sites are also there, the fallopian tube, the rectovaginal pouch, okay, in the peritoneum, anywhere it can happen. Risk factors are very important. So remember, again, it is a hyperestrogenic state, and the typical presentation would be a woman with a low parity, nulliparous or low parity, okay, because infertility is very common, or women who have delayed childbearing, okay, family history also, obstructive Mullerian anomaly, okay, I'll list them out: imperforate hymen, transverse vaginal septum, cervical agenesis, vaginal agenesis. Okay, and also very important, have you heard of O-Vera syndrome? O-Vera syndrome क्या होता है? It is seen in uterine didelphys. Okay, so what happens didelphys में क्या होता है? You have two separate uteruses, okay, with two separate cervices. ठीक है, इनमें क्या होता है कि one very rare variant, it's a rare variant of didelphys. ठीक है, इसमें क्या होता है? There is a half vaginal septum. So OHV क्या है? Obstructed hemivagina. That means half of the vagina is obstructed. As a result क्या होगा? यहाँ पे hematocolpus, hematometra और इस साइड पे endometriosis हो जाएगा. एंड उसी साइड का किडनी एब्सेंट होगा. Ipsilateral renal agenesis. So there's some problem in the embryology on this side. So obstructed hemivagina with ipsilateral renal agenesis, and the common presentation of this rare variant of didelphys is endometriosis, okay, because of this obstructed hemivagina. So overa, imperforate hymen, transverse vaginal septum, agenesis of the cervix or of the vagina, these are very rare actually, but they can result in this. And dioxins, remember, one of the environmental factors which is proven to cause endometriosis, nobody knows why, is dioxin. Okay. Now, symptoms. I always teach this because my professor always taught me this, is the 5 Ds of endometriosis. ठीक है, क्या क्या 5 Ds होते हैं? First है dysmenorrhea. And dysmenorrhea का typical feature क्या है? It is worsening dysmenorrhea. Worsening means the typical history in your question will come that the patient has triple dysmenorrhea or worsening. Triple का मतलब पहले premenstrual था, फिर menstrual हुआ, अब post-menstrual भी है. So she has pain premenstrually, menstrually, and postmenstrually. Okay, and it keeps worsening with every period. Okay, then you have dysgeusia, that means painful defecation. And this is common if you have rectovaginal deposits. इसका क्या मतलब है? So ये आगे bladder है, ठीक है, यहाँ पे uterus है और यहाँ पे rectum है. तो यहाँ पे क्या है? What is this area? This is the pouch of Douglas. Okay, this area is the pouch of Douglas. And endometriotic glands यहाँ पे गिरते रहते हैं क्योंकि empty space है और यहाँ पे they grow, and the endometriosis which you see in the rectovaginal area is called rectovaginal endometriosis. Okay, when you examine this patient, when you're doing a PV or a PR, you'll feel nodularity in the area between the rectum and the vagina. Okay, so this is a typical feature of endometriosis. So buzzword है nodularity in the rectovaginal area. Also because ये जब blood collect होता है ना यहाँ पे endometriosis में, it causes adhesions. Adhesions मतलब फाइब्रोसिस हो जाता है बिटवीन दो स्ट्रक्चर्स. सो उससे क्या होता है? ये यूट्रस को पीछे खींच लेता है. दीज एडहेजंस कॉज द यूट्रस टू गो बैक. सो द यूट्रस बिकम्स रेट्रोवर्टेड, ओके, एंड फिक्स्ड. नॉर्मल यूट्रस एंटीवर्टेड होता है, मोबाइल होता है, but because of these adhesions it becomes retroverted and fixed, and this is the typical clinical finding of a endometriotic uterus. तो अगर ये buzzwords आपको question में दिख रहे हैं, without a doubt, this is endometriosis. This is not malignancy. You might think ये malignancy है. Nodularity, retroverted fixed uterus is more likely to be in a young woman whose nulliparous is very, very likely to be endometriosis. Okay, dysmenorrhea, dysgeusia, then what else? dyspareunia. This is deep dyspareunia. Matlab on deep penetration, she has pain, and this is also because of these rectovaginal deposits. Okay. And the third D is a dull, aching abdominal pain. Okay. So this is separate from dysmenorrhea. In other times of the cycle, also, she'll always be in pain. And the fifth D is डिसफर्टिलिटी. तो इसको डी बनाने के लिए मेरे प्रोफेसर ने इसको डी कर दिया, इनफर्टिलिटी को डिसफर्टिलिटी कर दिया, but it's very easy to remember this. Okay, so these are the 5 D's of dysmenorrhea. Always remember this. And remember, AUB is not a common symptom of endometriosis. Okay, if your patient has AUB and has endometriosis, think of something else. Maybe she has fibroids, maybe she has endometrial hyperplasia, but by itself, endometriosis rarely causes AUB. That's why it's not even in the 5 Ds. Okay. Signs I've told you, typically look for a retroverted fixed uterus and nodularity in the pouch of Douglas. Okay. What is so we usually say, what is the best diagnostic investigation for endometriosis? And the answer is a laparoscopy. तो अगर best पूछा जाए या gold standard पूछा जाए, best या gold standard, मतलब how will you definitely diagnose endometriosis? Answer is laparoscopy and biopsy. But remember, सबको हम laparoscopy नहीं करते. Young 18-year-old girl comes with these symptoms. Okay, she's not concerned about fertility abhi, she's not married. हम सीधा थोड़ी laparoscopy करेंगे. It's an invasive procedure. We won't do that. Okay. So the next investigation, if you're suspecting endometriosis, is usually a ultrasound. Okay. And the typical appearance of this what is this? This stippled appearance. Yes, small, grayish dots. This is called, actually the picture of an endometriotic or a chocolate cyst. That is an ovarian cyst, and this is nothing but old blood. That's why it is called chocolate cyst, because the content is old blood. That's why it's brownish in color. Okay, so this is the typical endometriotic or chocolate cyst. But laparoscopy, I told you, is the gold standard. You're actually seeing the deposits, you're seeing the adhesions, you're seeing the nodularity, you're taking biopsies from there. And at the same time, you can actually treat. What is the treatment? If it's a chocolate cyst, you will do a cystectomy. This very commonly comes as a question. A laparoscopic cystectomy. That means पूरा ovary नहीं निकालोगे, सिर्फ उस cyst को निकालोगे. ठीक है? And you will also do a laparoscopic adhesiolysis. मतलब जहाँ adhesion बने, जहाँ endometriotic implants है, वहाँ वो bleed करके, it just causes everything to be stuck. So you have to gradually clear all the stuck portion, and that's called a laparoscopic adhesiolysis. Okay. So treatment of endometriosis, as I said, सब में surgery नहीं करते हैं. ठीक है? Surgery is done only if indicated. So depending on the symptoms, the age, कहाँ पे endometriosis है, whether she's interested in fertility, any previous therapy will help you decide whether you're going to do medical management or you're going to do surgical management. Now, just as a general rule, you can remember that if pain is the primary symptom, we usually do medical management. This is just a rough rule. It is not exact. Okay, every patient is different. But if infertility is a concern, is the main symptom, then we usually go for surgical. Okay, because infertility may we will have to clear out what happens in why are these women infertile? Because of the loss of anatomy. Okay, the tubes are stuck and they are not able to pick up the oocyte. So you have to restore normal anatomy, and that is the aim of surgical management. You're going to remove this big chocolate cyst, you're going to do a ovarian cystectomy. Along with that, you're going to ablate or excise the other endometriotic implants and do an adhesiolysis and try to restore normal anatomy. That is if fertility is a concern. But suppose her family is complete, or she's a young girl who's not married yet, or married but doesn't want kids yet, you can give her medical management. Now, the aim of medical management, so this NSAIDs are for symptomatic relief, but the aims of giving all these three drugs, and remember COCs are combined contraceptive pills, पर हम इनको continuous देते हैं. हम normally जब हम family planning के लिए देते हैं, we give a break. We give 21 days, then break, then 21 days, then break. उस break में क्या हो रहा था? She's getting her period. पर अगर हम continuous देंगे तो period बंद हो जाएगा. So you're creating a state of amenorrhea by giving these medicines. Amenorrhea से क्या हो जाएगा? Amenorrhea say what's going to happen? There is not going to be any retrograde menstruation, and the endometriotic implants or the collection will gradually disappear. Okay, or at least it won't progress further. So her pain will settle down. जो हर बार period के time pain होता है वो नहीं होगा if you make her have amenorrhea. For some time you can give her temporary relief. Okay, so continuous contraceptive pills, progesterones again continuous, or you can put in a Mirena. तो अभी तक हमने Mirena कहाँ कहाँ पढ़ा है? हमने पढ़ा है एडिनोमायोसिस में, फाइब्रॉइड्स में जिसमें कैविटी डिस्टॉर्ट नहीं हो रहा है, एंड एंडोमेट्रियोसिस में. ओके, और एक और जगह हम पढ़ेंगे एंडोमेट्रियल हाइपरप्लेजिया में भी अभी हम पढ़ेंगे. ठीक है, सो इट्स गिवन इन ऑल दीज कंडीशंस. ओके, एंड इट्स गिवन it's also, apart from these uses, it's also used as a contraceptive. So these are the non-contraceptive benefits. And how does it act? I told you जहाँ progesterone दे रहे हो, it's causing endometrial atrophy. तो खाली यूट्रस के अंदर एट्रोफी नहीं हो रहा, यूट्रस के बाहर जो implants हैं, they are also becoming atrophic. So her pain is settling down. So this is medical management primarily if pain is your main problem. If infertility is the main problem, it's better to do a adhesiolysis, clearance of all the endometriotic spots, and a cystectomy if there's a chocolate cyst. And that is what is preferred. Luna is what? Luna का full form क्या है? Luna का full form है the laparoscopic uterosacral nerve ablation. So if all these pain relief measures don't work, medicines, Luna is basically for pain relief. In severe endometriosis, आपने सब कुछ करके देख लिया, उसको पेन में रिलीफ नहीं हो रहा है, then you ablate the uterosacral nerves because पेन का main root ये है. ठीक है, or you just do a hysterectomy with a bilateral salpingo-oophorectomy. Remove the uterus and the ovaries also are usually removed in endometriosis. Okay, so this is management of endometriosis. Next comes endometrial hyperplasia. Now, endometrial hyperplasia is actually a pathological diagnosis. That means हम देख के ultrasound पे नहीं diagnose करते. It's a pathological diagnosis, and you have two main types of endometrial hyperplasia. So पहले 4 types होते थे, but now we've come down to 2 types. But I'll tell you both the types. One is simple and complex. Simple में with atypia, without atypia. Complex में भी with atypia and without atypia. Okay. Now what is the new classification? Now the new classification says that there's no simple, complex or anything. It's just with atypia and without atypia. Okay, now with atypia, of course, the risk of malignancy, which malignancy? Endometrial cancer is high. Right, so जहाँ पे atypia दिख रहा है, that means what are you going to do? You're going to do a hysterectomy. और जहाँ पे atypia नहीं है, what are you going to do? You can give high dose progesterone, again, which is usually given by a Mirena, and this will cause endometrial atrophy. So this is the usual plan, how we go about this. Okay, and this is how a normal TVS looks like on the ultrasound? Can you see this is the endometrium? This is seen as 3 lines, okay, in the proliferative phase. So a proliferative phase means the first 14 days of the cycle. You can see this beautiful trilaminar endometrium, okay, और ये वाला part myometrium है. Okay, this is a normal looking TVS. This is a TVS. Can you see now? This is the endometrium, how thick it looks. Okay. So the classical presentation of endometrial hyperplasia. How is this patient going to present? This patient is going to present, we're talking, not talking about postmenopausal, अभी हम premenopausal की बात कर रहे हैं. This patient is going to present usually a lady between 40 to 50 years old. That means perimenopausal age group. With what complaint? With heavy menstrual bleeding, matlab menorrhagia. Okay. Or a very common other history is 2 to 3 months of amenorrhea followed by heavy bleeding. Okay. And usually again, these women are nulliparous or low parity. Okay, so your question will be para 1 living 1 42-year-old lady presents with heavy menstrual bleeding after a period of 2 months amenorrhea. And then they give you this ultrasound image. So what will you do next? They will ask you. So I told you it's a histopathological diagnosis. So first we have to take a biopsy. So we're going to take a biopsy from the endometrium. Okay, and how can we take a biopsy? I'll just come to that. This is another picture, same, so showing the same thing. So can you see? ये तो thickened है. This endometrium is thickened. Along with that, you see these cystic spaces inside the endometrium. So this is also not a nice endometrium, especially if you're seeing cystic spaces. Cystic spaces inside the endometrium are typically seen with tamoxifen. So women on with breast cancer on tamoxifen therapy. Okay, so tamoxifen is a selective estrogen receptor modulator. So tamoxifen has anti-estrogenic effect on the breast. That's why we're giving it for breast cancer, but it has estrogenic effect on the endometrium. So the downside is it's going to cause endometrial hyperplasia. Okay, and so women on tamoxifen are advised yearly ultrasounds, yearly TVS. Okay, so that we don't miss a hyperplasia or a malignancy. Okay, and if the ET is thickened, we will take a endometrial biopsy. This can be taken in the OPD itself. It's called a office endometrial biopsy, and this question has come in your exam. They've shown you an endometrial aspiration cannula, which is a thin plastic cannula. It's a very thin plastic cannula which doesn't require cervical dilatation. That's why you can take it in the OPD. Office का मतलब OPD. हमारा office क्या है? हमारा office हमारा OPD है. इसलिए हम कहते हैं office biopsy. ठीक है. Second way you can do it is by doing a dilatation and curettage. Okay, that means हम cervix को dilate करके हम curette से, I'll show you the instruments in the end. Okay, but this is how a curette looks like. We curette the endometrium with a sharp end of the curette. ठीक है. Or the gold standard, अगर कोई पूछे what is the best way to obtain an endometrial biopsy, the answer is a hysteroscopic guided biopsy. इसका क्या मतलब है कि हम हिस्ट्रोस्कोप डालें यूट्रस के अंदर, we actually see the endometrium, see which area looks abnormal, and then take a guided or a directed biopsy, not a random. These two are blind procedures. ठीक है. OBG में हमारा आधा से ज्यादा काम blind होता है, because we're either doing PVs or blind DNCs. But so hence the gold standard is to actually look inside and take the biopsy. ठीक है. तो if they're asking you gold standard, the answer is hysteroscopic guided biopsy. So this is the flowchart which I just explained to you. If you've diagnosed endometrial hyperplasia on biopsy, remember it's not a clinical diagnosis, clinical suspicion hai, but you will of course diagnose it on a biopsy. It could either be simple or complex without atypia. Simple या complex important नहीं है. Important क्या है? With atypia, without atypia. If there is no atypia, the best thing is give either oral progesterones, but better is to put in the Mirena, levonorgestrel intrauterine device. ठीक है? Mirena डालने के बाद उसको छोड़ना नहीं है. You have to still repeat biopsies every 6 months. Usually we do. एंड आप बायोप्सी के लिए भेजते रहोगे जब तक वो कंप्लीटली नॉर्मल नहीं आता है. ठीक है. एंड एटिपिकल एंडोमेट्रियल, अगर एटिपिकल है देन वंस यू सी द वर्ड एटिपिकल इट मींस इट इज प्री मैलिग्नेंट. In fact, the risk of malignancy is as high as 27%. Okay, so you have to do a hysterectomy and remove the source of the estrogen also. So to do a ovarectomy also, remove the entire uterus with the tubes and the ovaries. But suppose your question comes, a young 30-year-old with atypical hyperplasia. She's not yet completed her family. Okay, she's nulliparous. She doesn't want a hysterectomy. What can you do? You can put her on high dose progesterone, same as this. Mirena डाल दो या oral progesterone दे दो. Keep doing biopsies every 3 months till it regresses. Okay. Then once it's regressed, ask her to plan family. And once she's family is complete, the end treatment is still remains doing a hysterectomy. Okay. So this is the flow chart. It's very, very important. Very simple to understand. It is a histopathological diagnosis, number one. नंबर टू, जहाँ पे एटिपिया दिख रहा है वहां पे आप हिस्टेक्टोमी विद बीएसओ करोगे. जहाँ पे विदाउट एटिपिया है यू विल गिव प्रोजेस्ट्रॉन्स, प्रेफरेबली इफ द चॉइस गिव्स यू, प्रेफरेबली पुट इन अ मिरीना if there is no atypia. Okay. Next comes this topic which a lot of discussion, and I don't know, I realized today that my bad, I shared a story of somebody who had given the wrong answer. ठीक है, so वो मेरी गलती है, मैंने ठीक से पढ़ा नहीं था. So I will be more careful in the future. But causes of PMB, please remember that we are most worried about malignancy. But मेरे पास in a normal OPD, if I see 15 to 20 patients per day, 2 patients are PMB. 2 to 3 patients out of 20 मेरे PMB के होते ही होते हैं. ठीक है. And malignancy नहीं होता इनमें. So malignancy is actually very, very rare. But if I'm doing 15 biopsies a month, approximately I do, okay, one comes out malignant. It's not common, but I should not be missing that one patient. That is important. Okay. So जब a patient comes with PMB, our main worry is cancer, right? And which cancer can cause PMB? The two most common cancers are cervical and endometrial. Cervical in the developing country like India, matlab low socioeconomic group, I won't say India, because we see a lot of endometrial cancers also. In fact, I feel I see more endometrial than cervical. So in low socioeconomic group, cervical cancers. In high socioeconomic group, you see endometrial cancers. Okay, so this is our main worry, but this causes 10% of all PMB. This causes 10% of all PMB. ठीक है. बाकी 80% क्या cause है फिर? ठीक है. बाकी the main cause, so the most common cause of post-menopausal bleeding is a atrophic endometrium or a senile endometritis. It's also called a senile. Senile का मतलब old है ना. सेनाइल एंडोमेट्राइटिस, वो क्या होता है? ये यूट्रस है. ठीक है. अब यूट्रस में एंडोमेट्रियम बहुत पतला हो गया है. ठीक है. बहुत पतला हो गया मीन्स लेस देन 1 mm और 1 or 2 mm, बहुत पतला ना. इमेजिन 1 mm थिकनेस किसी चीज का, और उसके जस्ट बिलो कैपिलरीज होते हैं. ओके. and those capillaries can suddenly break through and cause breakthrough bleeding. Okay. And or bleed. And so this is the most common cause. थोड़ा बहुत trauma हुआ, not even any trauma, जरूरी नहीं कि trauma हो, they just tend to bleed. Okay. And usually this bleeding will be very mild. So mild bleeding, this is another clue. If the bleeding is mild, like spotting, you are not that worried. But both of these will cause more heavy bleeding. But that is not the main thing you should see. The main thing that you should understand is PMB का most common cause is an atrophic or a thin endometrium. But our main worry is cancer. इसलिए PMB का जब patient आता है, you have to evaluate her in detail. You can't just say कि नहीं 80% में तो कुछ नहीं होता. It's okay. You can come back if you have another bout of bleeding. No, you have to evaluate her. And how do we evaluate her? We evaluate her by, of course, taking a history and examination. इसमें आपको बहुत सारे clues मिल जाएंगे. If you look at your previous questions, one of them says a 52-year-old lady. Okay, no, sorry, it comes as a 55 or 56-year-old lady who attained menopause at 52 years. So that is not a normal menopause. That's a late menopause. Okay, so if these are clues you're giving you, or maybe the woman had a history of heavy menstrual bleeding when she was having her periods. Okay, or maybe there she is an obese lady. Obese ladies, remember, obese girls, obese women have hyperestrogenism. Or maybe she has a history of PCOS. PCOS का history अगर है, remember, PCOS women are always at increased risk of endometrial cancer. तो कुछ ना कुछ clue would be there, even if it's not there. So once you do your history, take your history, the next thing you'll examine her, right? Examination में सबसे पहले हम क्या करेंगे? हम speculum डालेंगे अंदर, क्योंकि हमें देखना है कोई growth तो नहीं है. कहाँ पे? We are worried about a cervical growth. So if there is a obvious growth on the cervix, you're going to take a biopsy and then you have your answer. This is most likely a cervical cancer. But if the cervix looks normal, then what will you do? Then your main thing is, of course, you'll take a pap smear. But your main thing now, if the cervix looks normal, you are now worried about the other cancer, that is endometrial cancer. इसलिए TVS becomes important. TVS पे हम क्या देखेंगे? हम endometrial thickness देखेंगे. ठीक है? And endometrial thickness जो है, in a postmenopausal age should be less than or equal to 4 millimeter in the postmenopausal age. ठीक है? So if it's less than or equal to 4 millimeter, I am reassured. Okay, I am not that worried. So then I will say this is most likely senile endometritis. It's okay, you can go home. But अगर दोबारा bleeding हो रहा है, फिर भी we will do an EB, a biopsy, just to make sure this is not cancer. And अगर 4 millimeter से ज़्यादा है, मतलब 5 millimeter or more, you will definitely do a biopsy. You will not even send this patient home. You will make her lie down in your OPD if possible, do a office biopsy, otherwise do a hysteroscopic guided biopsy. Okay, so this is the flow chart, and this इस पे question आना ही आना है. Post-menopausal bleeding is very, 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 very important. If you pick up your previous year questions, usually a question आया होता है इससे. ठीक है, so no confusions in this. It's very, very clear, right? This is another important scenario. यहाँ से भी question आना ही आना है. And I've just put it all together here. Okay, so when we talk about a patient with vaginal discharge, remember, it could be infective, it could be physiological, or it could be infective. Okay, physiological discharge, remember, is acidic. The normal pH, vaginal pH in a reproductive age group is 4.5. In pregnancy, it goes even lower because of high estrogen. In pregnancy, the pH reaches 4. Okay, but reproductive age group में it is around 4.5. Okay, and because of this acidic pH, it can cause staining of the undergarments. So that's normal. अगर staining of undergarments दिया है, उसका ये नहीं मतलब कि it is an abnormal discharge. इसका ये मतलब है it is an acidic discharge. That's why it's causing staining of the undergarments. So remember, physiological discharge का दूसरा feature ये है कि it can cause, number one, it can cause staining of the underwear. It can also cause it is also more common around ovulation. It is also more common premenstrual. So if the discharge is more at these times, it is physiological. Also remember, there is no itching and no foul smell with a normal discharge. So this is how your question will come. They will say she is very worried because her undergarments are stained. तो very worried वाला term है ना, examiner आपको डरा रहा है, ठीक है, वो physiological ही है, ठीक है. Just a second. Okay, and infective discharge जो है वो important है to see which infection. So there are three main infections you should know: bacterial vaginosis, trichomoniasis, and candidiasis. ठीक है. Now, how do you differentiate between the three? Bacterial vaginosis is nothing but a change in the normal bacteria. Okay. And the discharge here is white, thin, homogeneous. ठीक है, thinnish grayish discharge होता है which coats the vaginal walls, and this is foul smelling, जो fishy odor term है, fishy odor. Okay, this is typical of bacterial vaginosis. Okay, remember, when she will not give any other symptom except a foul smelling white discharge, उसको ना itching होगा, ना dysuria होगा, and no redness of the vagina. The pH will be alkaline. Okay, not really alkaline, but 4.5 से ज़्यादा होगा, normal से ज़्यादा होगा. And how do you diagnose? By Amsel's criteria. Amsel क्या कहता है? 3 or 4 of them have to be there to say BV. First is clue cells. Second is smear बनाओगे, smear पे you put potassium hydroxide, you get that fishy odor. You get the typical fishy odor. Third is a high pH. We get these gloves with pH indicators. वो बताएगा pH high है. And fourth is the typical look of that discharge. ठीक है, the homogeneous milky white discharge. ठीक है, तो अगर 3 out of 4 है, then you know this is bacterial vaginosis. So what are your clue words or your buzzwords? One is this, or your images. This is a clue cell. Normally ये क्या cells दिख रहे हैं आपको? ये polygonal vaginal epithelial cells है. They are normally polygonal. ठीक है, ऐसे दिखते हैं, पर इनके जो borders है वो smooth है. If they are studded with these bacilli, then this becomes a clue cell. Okay, so if you look carefully, this is a blurred, it looks very blurry ना. Normally blurry नहीं दिखना चाहिए, normally अच्छा सा एक cell दिखना चाहिए ऐसे, but आपको blurry images दिख रहे हैं because these are clue cells. The borders are studded with bacilli. Okay, so clue cell is a buzzword. ठीक है, then alkaline pH is important. ठीक है, and no erythema, no dysuria, no itching, just discharge. Okay, and fishy odor. Fishy odor is also a buzzword. This is bacterial vaginosis. How will you treat BV? BV is treated by metronidazole. Okay, this can be given orally or as a vaginal pessary. Okay, you can also give secnidazole or tinidazole, but drug of choice अगर पूछा जाए, metronidazole is a better drug of choice. Trichomoniasis क्या है? Trichomoniasis है yellowish, if the word is yellowish or greenish. Okay, frothy, foul smelling, with severe pruritus and dysuria. And when you examine her, you find a cervix with reddish spots. Okay, this is called as colpitis macularis or strawberry cervix या strawberry vagina. दोनों पे reddish spots होंगे. Again, alkaline pH. And if you take a smear, what will you see? You will see this organism. This is a flagellated Trichomoniasis vaginalis, which is a protozoal organism. Okay, and that's how it looks like. So those are the buzzwords for trichomoniasis. इसका भी treatment same है. In addition, you will also treat her partner. Okay, because it is a sexually transmitted disease. Okay, then comes candidiasis. Candidiasis, you all know the thick curdy जहाँ पे है, it is candidiasis. यहाँ पे भी pruritus and dysuria will be there. यहाँ पे भी redness, the vagina will be inflamed. But यहाँ पे pH will be acidic. So fungus grows in an acidic media. Okay, and on putting potassium hydroxide, you will see the pseudo hyphae or the spores. So if this is your image, it is candidiasis. And if this is your image, you're going to treat her with antifungals. What are the common ones we give? We can give oral fluconazole, or you can give vaginal clotrimazole. These are the common ones. You can also give nystatin. You can give itraconazole. Okay, these are the other ones which are commonly given. So this is a very, very important slide. It's very easy to remember. Clue cells, bacterial vaginosis, strawberry cervix or strawberry vagina, trichomoniasis. Okay, and candidiasis is always in an acidic pH. Okay, pruritus and dysuria are seen in these two, trichomoniasis and candidiasis. They are not seen in bacterial vaginosis. Okay, so this is another important thing. Now coming to, we'll start moving towards gynae-onco. So we'll start with benign ovarian tumors and then we move on to malignancies. Just give me a minute, short 1 minute break. Okay, then we'll get back. Okay, so let's get back. Let's start with ovarian cysts. Okay, now in ovarian cysts, we'll just tell you what is the important things you need to know. You have something called functional ovarian cysts. So functional could be follicular cysts, okay, and luteal cysts. Now, luteal cysts we read yesterday, they are usually seen in pregnancy and they are because of high HCG levels. So, which luteal cysts did we read about yesterday? The theca lutein cysts, right? And what is done if they are found? Nothing is done. So, you're going to have an examiner who's going to ask you that a patient presents in pregnancy with very large ovarian cysts and is diagnosed to have theca lutein cyst. What will you do? ठीक है, तो इसमें भी nothing needs to be done. You're going to treat the source. You're going to take care of her molar pregnancy. Sometimes they are seen with multiple pregnancy because of high beta HCG level. So whatever the cause, that means the pregnancy is the cause. Once the beta HCG settles, the cysts will settle. You don't have to remove these cysts in pregnancy. Okay, you also see what is called a corpus luteal cyst. This is seen in a normal pregnancy, okay, and it basically provides progesterone to the fetus, to the pregnancy, till the placenta takes over and produces HCG. Okay, so corpus luteal cyst is seen in most pregnancies. It's secreting progesterone that's supporting the pregnancy till the placenta takes over, and this is usually by 10 weeks of pregnancy. Now, follicular cyst क्या होता है? Follicular cyst is basically any follicle which becomes more than 3 centimeters in size. It's basically something like the follicle has grown and the oocyte hasn't been released. So it's an unruptured follicle. मतलब ovulation नहीं हुआ है. And that's the commonest cause of a follicular cyst being formed. That's why it's called a functional cyst. What do you do in such circumstances? Here, if she's young, if she's in the reproductive age group, and the question that comes is there's a 5 centimeter simple ovarian cyst seen on ultrasound. The patient has mild pain or no pain, or it's an incidentally detected simple cyst. So remember, if it's less than or equal to 6 centimeters, nothing needs to be done. So just reassure or you can give her combined oral contraceptive pills. What do these do? These reduce the estrogen progesterone content in the body, and over time, these cysts will disappear. Okay. But if the cyst is more than 8 centimeter, then they have to be removed because they are very large. They can cause complications. They can undergo rupture inside or infection or hemorrhage. So a laparoscopic cystectomy, that means removal of the cyst, should be done. तो बाकी क्या करना है, 6 to 8 में क्या करना है, 6 to 8 में देखना है कि कोई वरिंग फीचर्स तो नहीं है. दैट मीन्स the treatment has to be individualized. So if here there's a raised CA125, what is this? This is a tumor marker for epithelial ovarian cancers. We'll come to this. Or any worrying features, that means the patient is having pain, okay, or the patient is, or the ultrasound is showing solid areas suggestive of maybe it is some malignancy, then you will do a laparoscopic cystectomy. But if it doesn't have any worrying features, you can also reassure her. So 6 से less कुछ नहीं करना है, 8 से ज़्यादा है remove करना है, 6 to 8 के बीच में हो, then you can think of conservative role versus surgical depending on case to case basis. Okay. Next is this image. What is this? This is a dermoid. Okay. Dermoid कैसे पता है हमें? It's also called a mature cystic teratoma. And how do we know it is a dermoid? Because of the typical hair, sebaceous material, and the calcific structures, that is the teeth like structures that you see. Okay, so it has components of all layers, the ectoderm, the mesoderm, and the endoderm. That is the typical feature of a dermoid. अब dermoid में important क्या है? Dermoid में remember treatment. If a dermoid is diagnosed, a laparoscopic ovarian cystectomy has to be done. Remember, these are usually benign. Okay. Also remember that they are very prone to undergoing torsion. Why? Because the sebaceous material makes them float in the peritoneal cavity. So float kar raha hai, so it easily gets twisted. So this patient will present usually with acute abdominal pain, not resolving with any treatment. Okay. Also remember it's the most common benign ovarian tumor in pregnancy. Okay. Also remember on ultrasound, the typical feature is called acoustic shadowing. अगर acoustic shadowing word दिया हुआ है scan पे, it is usually a dermoid. Okay. Also remember that I think we've talked about, there's something called the Rokitansky nodule. Okay, this is also typically seen in a dermoid. Okay, so remember they are benign. It's also called a mature cystic teratoma. They are prone to torsion. Treatment is a laparoscopic ovarian cystectomy. Okay, next is endometrioma. This we have already discussed. It's also called a chocolate cyst. And what will you do? You'll do a laparoscopic ovarian cystectomy. तो कोई भी benign ovarian cyst है ना, you'll do this, a laparoscopic ovarian cystectomy, whether it's a benign functional cyst, a follicular cyst, or a benign chocolate cyst, or teratoma. You'll do a laparoscopic ovarian cystectomy. Next, coming to epithelial ovarian tumors. Okay, these could be benign or malignant. So you have cyst adenomas and cyst adenocarcinomas, like that. Okay, or you have serous, you have mucinous, you have Brenner's tumor, you have clear cell tumors. These are all epithelial ovarian tumors. They could be benign, they could be malignant. Now, what are the risk factors? This commonly comes as a question. Risk factors for ovarian tumor, number 1 is low parity or nulliparity. That means women who don't have children. Why? Because this is the ovarian surface. ठीक है, तो यहाँ पे follicles होते हैं. तो जब ovulation होता है, this follicle grows and it ruptures on the surface. तो surface पे क्या होता है? Micro trauma हो जाता है. तो जब बार बार ovulation हो रहा है, बार बार ovary को trauma पहुंच रहा है, over many months, years, decades, what happens is eventually that leads to an area of malignancy. Now, women who have children are protected for some months to some years. जब तक वो pregnant है, जब तक वो breastfeeding कर रहे हैं, they are protected. So that incessant ovulation, बार बार ovulation से थोड़ा बहुत protection मिल जाता है, which is not seen in women who are low parity or nulliparous. That's why this is a risk factor. Also, girls who have early menarche for the same reason, late menopause for the same reason, are at an increased risk of incessant का मतलब है बार बार होना है, incessant ovulation, जिसके वजह से they are at risk of ovarian cancer. Then there are certain familial syndromes like BRCA1, which also increases the risk of breast cancer, BRCA2, and HNPCC. Okay, so these are all risk factors for epithelial ovarian tumors. Also remember what is one more which I missed is, which is important, is ovulation induction agents, especially clomiphene citrate. Clomiphene जब हम देते हैं, clomiphene citrate, if you remember, is an anti-estrogen. Okay, and what does this do? This, because it blocks the estrogen, what's going to happen is FSH LH will increase. Okay, and this will cause more follicles to grow. So you have multiple follicles growing, that is multifollicular development. कहाँ देते हैं क्लोमिफेन सिट्रेट? हम देते हैं एनओव्यूलर साइकिल्स में, गर्ल्स वुमेन हु हैव पीसीओएस. बट द डाउन साइड इज कि बहुत सारे फॉलिकल्स स्टार्ट डेवलपिंग. अब बहुत सारे फॉलिकल्स स्टार्ट डेवलपिंग, वो सारे रप्चर होंगे तो ट्रॉमा बढ़ जाएगा, है ना. सो द रिकमेंडेशंस आर दैट क्लोमिफेन शुड नॉट बी गिवन for more than 6 cycles in a row. So after 6 cycles of giving clomiphene, if she's not still yet conceived, give a break. Okay, because it can, you have to let the ovary heal also, right? Otherwise, she can have ovarian cancer. Okay, so these are the risk factors. What are the protective factors? So what is protective? Protective for ovarian cancer, number one, having more children. So multiparity. The more children she has, the more protection she has against ovarian cancer. What else? If you've done a tubal ligation, okay, so this is the uterus, ये tube है, ये ovary है, ठीक है. तो a woman who's undergone sterilization, tubal ligation, अपने tubes cut करती है इसके, है ना. What is going to happen? जो यहाँ से toxins थे जो ovary के पास जा रहे थे, those will stop going. So the ovary is protected against toxic material coming from here. Okay, so tubal ligation is protective. And third, very important, is combined oral contraceptive pills are protective. For which 3 cancers? Colorectal, endometrial, and ovarian. Okay, so remember CEO. Combined oral contraceptive pills are protective for 3 cancers: colorectal, endometrial, and ovarian. But they are bad for which cancers? They increase the risk of breast cancer, okay, and of cervical cancer. Cervical cancer ka plus minus hai, some evidence is for it, some is against it. But breast cancer, definitely COCs will increase the risk, but COCs decrease the risk of colorectal, endometrial, and ovarian cancer. Okay, so this is important to know. It's usually asked as a question. Okay, this is another important question. So how do we know whether the tumor is malignant or not? We usually get these tumor markers done, है ना? And these tumor markers which are done are raised in different types of ovarian cancer. So very important, CA125 we all know is a marker for epithelial ovarian cancer. Specifically which one? Serous cyst adenocarcinoma. Okay. Alpha fetoprotein is increased in yolk sac tumor. How will we remember this? जहाँ पे फीटस है, अल्फा फीटोप्रोटीन, तो फीटस के पास योक सैक रहता है ना, तो अल्फा फीटोप्रोटीन इज फॉर योक सैक ट्यूमर. LDH इज फॉर विच ट्यूमर? LDH, D है, so dysgerminoma. Okay, then beta HCG we all know is for choriocarcinoma, but this is not the normal choriocarcinoma. ये ovarian वाला choriocarcinoma, which is called as non-gestational choriocarcinoma. Okay, and inhibin A and B is for, inhibin we know is secreted by the granulosa cells. So granulosa cell tumor. Okay, so this is very, very important to remember. Okay, quick revision यहाँ पे learn कर लो, फिर दोबारा इसको learn करने की जरूरत नहीं है if you have learned it here. Okay, very easy to remember. The most common one is CA125. ठीक है, because this is the most common ovarian malignancy, serous cyst adenocarcinoma. तो इसलिए ये सबसे commonly हम check करते हैं. The other tumors are all rare tumors and they occur in the young women. Young women में अगर हम suspect कर रहे हैं ovarian malignancy, then we should get all these tumor markers done. Otherwise, usually we just do a CA125, especially if the woman is postmenopausal. Okay. Again, very commonly asked questions. What is this? This is a Schiller-Duval body. Okay. Well, how do we know this? Because it has a central capillary here. Okay. And this is seen in an endodermal sinus tumor or a yolk sac tumor. Schiller-Duval body. Okay. What is this? These are called Exner cells. Okay. And this is a coffee bean nucleus. Both are seen in granulosa cell tumors. Okay, so call Exner cells, coffee bean nucleus associated with granulosa cell tumors. What is this? Can you see these? ये जो cells है with a slight prominence on one end, these are called signet ring cells. Signet ring क्या होता है? A diamond ring like this is called a signet ring. ठीक है, जहाँ पे एक side पे prominent होता है. ये कहाँ पे होता है? This is seen in Krukenberg tumor. Krukenberg is what? What is Krukenberg? Krukenberg is not a primary ovarian tumor. It is a secondary ovarian tumor. मतलब primary कहीं और है, उसके deposits दोनों ovaries में आ गए हैं. So it's usually a bilateral solid ovarian tumor. And the most common site of the primary is the breast. And second most common site is the stomach. Okay. 1 second. Just a second. Okay, sorry. My mistake. My mistake. The most common site is stomach. And second most common site is breast. Please correct this. Okay, most common site is stomach. Second most common site is breast. So this is a Krukenberg tumor. It is a secondary ovarian bilateral solid tumor and the typical histopathology is a signet ring cell. What is this? These are Samoma bodies. Okay, and so Samoma bodies are typically seen in serous cyst adenomas or cyst adenocarcinomas. Okay, so serous cyst adenocarcinoma is where you see Samoma bodies. What is Meek syndrome? Meek syndrome was typically described for a solid ovarian mass that is a fibroma. This is an ovarian fibroma. It's usually a benign tumor with pleural effusion with ascites is called as Meek syndrome. Pseudo-Meek syndrome is the same finding but with any other ovarian or uterine tumor. So if you find any other ovarian tumor, with pleural effusion. With ascites, it is called as pseudo-Meek syndrome. Even a fibroid uterus can present with pleural effusion and ascites, usually because of peritoneal irritation. Then it is called as pseudo-Meeks. But अगर fibroma, ovarian fibroma है, then it is Meek syndrome. Okay. Now coming to a very, very important topic, that is cervical cancer screening and the HPV vaccine. Okay. First of all, you should be able to identify in this image what is the transformation zone. This area here is the transformation zone. Okay, what is the zone? It lies between this outer lining. So the outer lining is the original squamo-columnar junction. ठीक है, and ये जो inner lining है, this is the new squamo-columnar junction. ये SCJ क्या होता है? It is the basically the junction between the squamous cells of the ectocervix and the columnar cells of the endocervix. So the ectocervix has epithelial cells, okay, and the endocervix has columnar cells. और इन दोनों के जंक्शन को कहते हैं squamo-columnar junction. Now this junction changes with age as a woman reaches puberty, under estrogen exposure, this SCJ moves outwards. So the original HCJ moves outwards and a new SCJ forms, and दोनों के बीच का जो जगह है इसको कहते हैं transformation zone. And this is the zone which has the highest risk of malignancy. So this is where all your malignant changes are going to happen. इसलिए जब हम screening करते हैं, screening of cervical cancer is always from the transformation zone. Okay. So screening of cervical cancer, if we talk about, remember that the primary screening modality is no longer a pap smear. ठीक है? The primary, I write here, preferred screening modality now by all guidelines, including Indian guidelines, including American guidelines, including WHO guidelines, is by doing a HPV, human papilloma virus testing. ठीक है? कैसे करते हैं testing? जैसे हम pap smear लेते हैं. We put in a brush. This is how the HPV testing is done. This is called a cytobroom. तो ये वाला पार्ट एंडोसर्विक्स में जाता है, ये पार्ट ट्रांसफॉर्मेशन जोन एक्टोसर्विक्स पे रहेगा. फिर हम उसको रोटेट करते हैं few times and we put it in this media and send it for genetic testing. So this is the primary or preferred method of cervical cancer screening nowadays by all guidelines. And WHO says start screening at the age of 30. American Cancer Society says start screening at the age of 25. Some other guidelines say 21, but I don't think you're going to be asked when you start screening, but you can remember the standard one is the WHO, which is 30 years. And most other guidelines, including American guidelines, are 25 years. Okay, and what do they say? They say that HPV should be done every 5 years. In fact, WHO says 5 to 10 years. ठीक है, और वो ये भी कहते हैं अगर HPV नहीं है आपके पास, यू कैन डू अ पैप स्मियर. ठीक है, पैप स्मियर इज एन एक्सेप्टेबल टेस्ट जो हम पहले करते थे. दिस इज हाउ वी डू अ पैप स्मियर. एंड पैप स्मियर अगर कर रहे हो तो 3 years, once every 3 years. They also say you can do a co-test. Co-test क्या है कि दोनों करो, HPV and pap smear, do both. And if you're doing both, do it 5 yearly. ठीक है, तो ज्यादा कंफ्यूज नहीं होना है. HPV कर रहे हो तो once in every 5 years. पैप स्मेयर कर रहे हो once in every 3 years because HPV is of course better. And अगर दोनों कर रहे हो तो 5 years. ठीक है. Now this is what you need for a pap smear. This is a Cusco's speculum. This is a disposable wala. You mostly would have seen the stainless steel wala, है ना? This is a cervical or a cyto brush जो endocervix से sample लेगा. ये वाला जो है wooden spatula, it's called an Ayers spatula, और ये हमारा ectocervix से it will take a sample. So we take a sample from the ectocervix, then the endocervix, and we make a slide. And this slide we put in this jar or we spray a fixative. The jar has a fixative or we spray the fixative, and the fixative contains 95% ethyl alcohol. Okay, so this is important. Okay, and once we spray the stain, the fixative, we send it to the pathologist who looks under the microscope and will give us a report. Or we take an HPV and we send it to the lab and they will do genetic testing and give us a report. Okay? So these are the best tests, right? HPV is the best, second best is pap smear. And suppose हमारे पास दोनों ही नहीं है, then what can we do? We can do a visual inspection of the cervix. We put a speculum, we look at the cervix, and then we can put acetic acid, or we can put Lugol's iodine, or we can put both. Now, a pre-malignant lesion or a malignant lesion on the cervix will become white. Can you see this area? This is a aceto-white area on VIA, visual inspection under acetic acid. And the same area, अगर हम उस पे Lugol's iodine डालेंगे, will be iodine deficient. That means it will not take up the iodine stain. Okay. And this is called a iodine deficient. This is called visual inspection with Lugol's iodine. So these are done both in low resource settings where you don't have a lab or a pathologist to do the HPV or the pap smear. So you should know how both will look like. On acetic acid, suspicious lesion will become white, and Lugol's iodine डालोगे तो iodine uptake normal tissue में होगा, but abnormal tissue will not take up iodine. Okay. Now, if the HPV is positive, so तो हमने सबसे preferred test we did, preferred test was HPV, right? So we called a patient came for screening. We did the HPV. It came positive. What will you do? Okay. Now that she's HPV positive, she's at risk of cervical cancer. So we don't treat HPV. We won't give her acyclovir or anything like that. We know that she's at risk of cervical cancer. So what will we do? We can either do a pap smear if it's not been done, okay, or we directly send her for a colposcopy. Both are acceptable. Okay, but this is more ideal. Okay, ideally हमें pap smear कर लेना चाहिए, but colposcopy भी कर सकते हैं. Colposcopy क्या होता है? Colposcopy होता है magnification of the cervix. That means with the speculum, we put a machine, okay, which magnifies, which visualizes the cervix at a much more magnified view, up till 10 times the actual cervix. It zooms it up to 10 times. Okay, so we can see much finer abnormalities. Okay, and from any abnormal area, we then take a biopsy. Okay, now ideally we should be doing a pap smear. So we're going to do a pap smear. Now pap smear में कुछ कुछ आ सकता है. Pap smear में सबसे पहले आ सकता है NIELM. ये क्या है? Negative for intraepithelial lesion or malignancy. This basically means it's normal. So HPV positive, pap smear is normal. What do? We say looks okay, but let's review you after 1 year, not after 5 years, because she's still HPV positive. So you can't send her back to routine screening. You will call her back after 1 year, not after 5 years. Second possibility is she has any of the abnormalities on pap smear. क्या हो सकता है? There could be something called ascus. What is ascus? Atypical squamous cells of undetermined significance. मतलब कुछ तो गड़बड़ है, नॉर्मल नहीं है, पर हमें समझ नहीं आ रहा क्या गड़बड़ है ना? तीसरा आ सकता है एल सिल. एल सिल क्या है? लो ग्रेड squamous intraepithelial lesion. So this is low grade. Okay, and fourth आ सकता है high grade. ठीक है, H cell, high grade squamous intraepithelial lesion. So any of these three come, you're going to directly do a colposcopy. Any of these three. ठीक है, ascus, L cell, H cell. So only if it's normal, you can send her back to regular testing. If it comes ascus or L cell or H cell with the HPV positive status, you're going to tell her that I'm going to do one more test. That is, I'm going to look at the cervix under magnification and look for any abnormal areas. और उस एबनॉर्मल एरिया से मैं बायोप्सी लूंगी। ठीक है। अब बायोप्सी में क्या क्या आ सकता है? बायोप्सी में आ सकता है नॉर्मल। ठीक है, नॉर्मल आ गया, यू वेरी हैप्पी, यू विल कॉल हर बैक आफ्टर 1 year, नॉट आफ्टर 5 years। ओके। सेकंड आ सकता है CIN1, या फिर आ सकता है CIN2, या फिर आ सकता है CIN3, या फिर आ सकता है CIS। CIS क्या है? कार्सिनोमा इन सिटू, which is basically a microscopic carcinoma which is limited, okay, very very limited to the basement membrane, and this is also called as stage 0 cancer. Okay, so these are the possibilities on the biopsy, or you can even get frank malignancy, stage 0 or stage 1A microscopic cancer you can get. Okay. Now, if it is normal, nothing to be do, reviewer after 1 year. But if it is CIN1, CIN1 means low grade. तो यूजली अगर एल सेल आता है पैप्स पे, यू एक्सपेक्ट कि पैप्समियर पे CIN1, बायोप्सी में CIN1 आएगा। और यूजली अगर एच सेल आता है पैप्स पे, आप एक्सपेक्ट करोगे बायोप्सी पे CIN2 या 3 आएगा। दिस इज हाई ग्रेड। ओके, so if it is a low grade lesion, what are you going to do? You're going to do a cervical ablation. Ablation का मतलब क्या है? आप उसको हीट से जला दोगे या cold से you're going to freeze it. So you're going to do either a thermal ablation or you're going to do a cryotherapy, a cryoablation. Freeze the cervix or burn the cervix. Okay, but you're not going to cut off or remove the cervix. But if it is high grade, then you will have to do an excisional procedure. That means you're going to cut off the transformation zone, what is called a large loop excision of the transformation zone, LLETZ, also called a LEEP, loop electrosurgical एक्सिजन प्रोसीजर। तो LLETZ या लीप दिखे आपको, इसका मतलब क्या है कि आप ट्रांसफॉर्मेशन जोन को निकाल रहे हो। यू कैन ऑल्सो डू अ कोनाइजेशन। कोनाइजेशन मीन्स दिस इज द सर्विक्स, you are taking, this is the os, you are removing this much area of the cervix, matlab almost the entire ectocervix, and you're going inside till the endocervix. Okay, and in a leap you're removing less area, but you're cutting off this part in a loop electro excisional procedure. So this is what you're doing. If it is CIN2 or 3, CIN1 hai, so you're ablating it. 2 या 3 है, you're excising the cervix. Okay. So this is what you need to know from this entire long lecture of cervical cancer screening. If it is CIN1, you can also co-test after 1 year, but it's better to do an ablative procedure. और अगर CIN2 या 3 है, preferred is LETS या LEAP. Okay. And forget this. Okay. LEAP or LETS is preferred, or you do a conization. Okay, so this is an ablative procedure. You can either do thermal, that is heat, or cryo. Cryo is with nitrous oxide. This is a cryo probe which is used to freeze the cervix, okay, at minus 89 degrees Celsius. Okay, and it freezes, it destroys the cervix up till 5 millimeter depth. You can also do a laser ablation. So thermal, cryo, or laser, and this is done for CIN1. For CIN2 or 3, you're going to do excisional procedures, and the excisional procedure of choice is the LETS. LETS is कि ये तो cone, this is a conization. LETS is just taking out this much. Okay, going more deep inside is cone. कोन हम सिंपल स्कैल्पल से करते हैं, कोन हम तब करते हैं जब हम सस्पेक्ट कर रहे हैं कि अंदर भी मैलिग्नेंसी हो. So you feel that the lesion is extending into the endocervix, or you're suspecting cancer, okay, or you're having a recurrent lesion कि एक बार आपने लेट्स कर दिया, दोबारा फिर से हो गया उसको CIN3. So recurrent lesion, take out more tissue. Conization means you're taking out more tissue. Or there is a cytology, histology discordance. What does this mean? कि आपके pap smear पे L से लाया, तो आप expect करोगे कि CIN1 आएगा on the biopsy, but biopsy पे आया CIN3. This is called a cytology. This is cytology. This is histology discordance. If you can remember this, very good indications for cold knife conization. If you can't remember this, it's okay. Just remember conization से ज़्यादा tissue निकलता है. So if you're suspecting more extensive lesions, you'll do a conization. But otherwise, treatment of choice for CIN 2 or 3 is a large loop excision of the transformation zone. Okay. Very, very important, HPV vaccine. Prevention of primarily CIN and CA cervix. We all know this. Okay. It also protects against vulva, vagina, anal canal, penile, oropharyngeal. So 5 cancers. Okay. CA cervix to hai. Okay. 1 vulva, vagina, anal canal, penile, and oropharyngeal. Total 6 cancers. Apart from that, CIN and genital warts. Okay, so this is what it prevents against. This comes as a question. It contains the L1 synthetic capsid protein. This is a virus-like protein. Okay, and the types of the vaccine. Kya vaccines do we have? We have the bivalent. Bivalent is mainly against the two most important high-grade types are 16 and 18. Okay. This is Cervarix. How do you remember Cervarix? B and C come together in the alphabet. So Cervarix is bivalent. Okay. Gardasil is quadrivalent, and Gardasil is protective against the low-grade types also. 6 and 11, remember, cause genital warts. They don't cause malignancy. They cause genital warts. So they are called the low-grade types. Okay. And 16 and 18 are the highest grade. Most common causing cancers are 16 and 18. So Gardasil में चारों हैं, ठीक है? And the newest one is Gardasil 9, which is a nonavalent, 9 types. So 6, 11, 16, 18 are there. Apart from that, 31, 33, 45, 52, and 58. Okay. The newest one, though, is the Indian wala. Indian wala is Servavac. Okay, made in India. This was released in 2023 June. Okay, and this is also the same as Gardasil. So Gardasil or Servavac, same hai, quadrivalent. This is quadrivalent. Okay, and now it is available in India. So Servavac, okay, is India's vaccine. It is quadrivalent and it is effective against 6, 11, 16 and 18. हमारा guideline क्या कहता है कि girls, so who are you vaccinating? Girls between 9 to 26, right? If she's less than 14 years, 2 doses. If she's more than 15 years, then 3 doses. Okay, and you can also give catch-up vaccine till the age of 45 years. So if she's not been vaccinated and you feel she's at high risk, it's better to give the vaccine even if she's above 26 years old. So 9 to 26 is your main category of patients, but you can give a catch-up vaccine till 45. Till 14 years, you're giving 2 doses. After 15 years, you're giving 3 doses. Okay. Now, cervical cancer. Okay, cervical cancer ka etiology we know is the human papilloma virus. All right, we know the most common type is the squamous cell carcinoma, and this is what you're seeing when the transformation zone gets affected. The tumor spread is mainly by lymphatics. That's why whenever we're doing a radical hysterectomy, we're also always doing a pelvic lymphadenectomy. You're removing the pelvic lymph nodes. What are the pelvic lymph nodes? The common iliac group of lymph nodes, the internal iliac group of lymph nodes, the external iliac group of lymph nodes, the sacral group of lymph nodes, and the obturator group of lymph nodes. 5 group of lymph nodes which come under pelvic lymph nodes. So remember, जब surgery और जब हम radiotherapy देते हैं तब भी हम lymph nodes को target करते हैं. So because the main spread is through the lymphatics. Very important. Okay. How does this patient present with? The classical symptoms which you should not miss in your question are which are the most common abnormal uterine bleeding patterns? She can come with intermenstrual bleeding or post-menopausal bleeding or post-coital bleeding or what is called as contact bleeding. Because there's a growth here, anything which touches it, it will start bleeding. Okay, so intermenstrual bleeding, post-menopausal bleeding, post-coital bleeding. foul smelling vaginal discharge, cachexia. These are the symptoms which the patient will present with. When you examine her, the signs on examination, when you put a pus speculum inside, you will see a fungating or ulcerative growth on the cervix, okay? And this growth is going to be bleeding on touch. So it's friable. Friable का मतलब क्या है कि टिश्यू आपके हाथ में आ जाता है. आप पीवी करोगे, they will find the tissue comes in your hand. It bleeds on touch. And whenever you see a growth on the cervix, you are going to take a biopsy using this instrument. This is a punch biopsy forceps. Okay, this is how it looks like. It's called a punch biopsy forceps. Okay, so you take a biopsy from the growth. So if this is the cervix, यहाँ पे growth है. Where will you take the biopsy from? You will take the biopsy from the periphery of the growth, not the center, because center will be necrotic. From the periphery of the growth, you have to take the biopsy so that you get some tissue, viable tissue. Okay. Staging is very important. So staging, I'm not going to discuss of any other cancer except cervical cancer, because cervical cancer staging is the most important. Okay, you should not know again the detailed staging, but a brief overview. Now, important, it is a clinical staging. Jo ovarian and endometrial cancers, these are surgically staged. इसका क्या मतलब है? ओवेरियन एंड एंडोमेट्रियल कैंसर में वी आर डेफिनेटली गोइंग टू ऑपरेट, वी आर गोइंग टू डू अ सर्जरी because you have to do a surgical staging. Okay, so what's called a staging? Laparotomy with a TAH plus BSO. You're going to remove the uterus. You're going to do a bilateral salpingo-oophorectomy. You're going to take biopsies from everywhere, the omentum, the peritoneum, okay, and you're going to do what is called especially in ovarian cancer, you're going to do what is called a optimal debulking. इसका क्या मतलब है? You are going to remove all the visible tumor tissue. चाहे लिवर पे हो, चाहे डायफ्राम के अंडर सर्फेस पे हो, जहां जहां आपको मैलिग्नेंट टिश्यू दिख रहा है विजिबल, यू गोइंग टू ट्राई एंड रिमूव इट टू अचीव एन ऑप्टिमल डीबल्किंग. ऑप्टिमल डीबल्किंग का मतलब है लेस देन 1 सेंटीमीटर ऑफ ट्यूमर टिश्यू is left behind. Okay, so both ovarian and endometrial cancer is surgically staged. उसके बाद ये आप सब biopsy के लिए भेजोगे. The report will come. So depending on what the report is, where all the tumor has spread, you will stage the cancer. Okay, so ovarian cancer, remember the treatment is primarily surgery followed by chemotherapy. Endometrial cancer, again, treatment is primarily surgery followed by chemo or radiotherapy. Okay, so surgery forms the mainstay of both ovarian and endometrial cancer because that's how you're also staging the tumor. But cervical cancer is a clinical staging. Okay, I will examine her in my OPD. I will tell her that this looks like stage 1 or 2 or 3 or 4. And I will also, my staging, I can also help with certain investigations. I can get an MRI done to see if lymph nodes are involved. I can do a cystoscopy to see if the bladder is involved. So I can use some investigations and stage her better, but the staging is clinical. Okay, that's very important to understand. And then treatment is either surgery or radiotherapy, not even radiotherapy, chemoradiation, depending on the stage. So either can be done. Okay, so that's very important to understand कि surgery सब में नहीं करते हैं in cervical cancer. In fact, surgery is limited to very early stage cancers. Now, what is stage 1? Stage 1 means confined to the cervix. यहीं पे tumor है, ठीक है? And this is classified as stage 1A and 1B. 1A means microscopic cancer. मतलब आपको visible नहीं दिख रहा है, ठीक है? इसमें again 1A, 1, 2, 1A1, 1A2, but I'm not going into that. Microscopic cancer. 1B क्या है? Macroscopic cancer. मतलब it's visible. but it is still only on the cervix. इसमें again you have 1B1, 1B2 and 1B3 depending on the size, less than 2, 2 to 4, more than 4. Just a second, everybody. Just a second. I just have to send my son's homework. 1 second. Okay, sorry. Okay, so 1B is macroscopic, that means visible. तो दोनों में हम सर्जरी कर सकते हैं. So in 1A we do what is called a type 2 radical hysterectomy, जिसको हम कहते हैं वर्दाइम्स hysterectomy. ठीक है. एंड 1B में हम करते हैं टाइप 3 radical hysterectomy, जिसको हम कहते हैं मीक्स hysterectomy. ठीक है. अब you don't have to know the difference between type 2 and type 3, but just remember radical hysterectomy means you're removing more lateral tissue. You're going more laterally. You're not with the uterus. In type 2, in a simple hysterectomy, we remove from here. In a type 2, we go like this. In a type 3, we go right till the pelvic wall. That means lateral jo para uterine tissue hai, all the tissue next to the uterus has to be removed. So this is a simple hysterectomy. This is a type 2. This is a type 3. Okay. So this is 1A and 1B. What is stage 2? Stage 2 is divided into 2A and 2B. 2 का मतलब है कि cervix से beyond चला गया है. Okay, and in 2A it is involving the upper 2/3 of the vagina, not in the lower portion, only the upper part. Or in 2B it has gone into the parametrium, but not to the pelvic wall. Okay, so this is type 2B. Now 2A तक इसको भी हम further divide करते depending on the size. 2A1, 2A2, not important. Just remember till small 2A. Small 2A मतलब 2A1. छोटा 2A है तब तक आप सर्जरी कर सकते हो. यहाँ पे भी you can do a type 3 radical hysterectomy. But once it has reached this and beyond, type 3, type 4, type 2B, you can't, there is no role of surgery. Here you're only going to do chemo radiation. So any large tumor or type 2B and above, radiation, chemo radiation is better. Okay. So type 1A, you're going to do a type 2 radical hysterectomy. In fact, if it's very small, type 1A1, you can even do a simple hysterectomy or a conization if the woman wants to preserve her fertility. But itna detail mein nahi jaate hain. Just remember, for very early stage cancers, it's a hysterectomy is possible till type 2A1. But uske beyond, you're going to do a chemo radiation. So what is stage 3? Stage 3, the tumor has come till the lower 1/3 of vagina. This is 3A. And 3B, it has gone till the lateral pelvic wall. Now, if it's gone to the lateral pelvic wall, they may be hydroureteronephrosis. What is this? The ureter is here, so this ureter gets obstructed, so there is obstructive uropathy. There is dilatation of the ureter and the kidney. And that's why the most common cause of death in cervical cancer is renal failure because of obstructive uropathies. Okay, so this comes as a question. The most common cause of death in cervical cancer is renal failure. Stage 4 is 4A, 4B. 4B is local metastasis to the bladder or the rectum, and 4B is distant metastasis. Treatment is surgery or radiotherapy. Radiotherapy you can in fact give for all stages. Stage 1 to 4, all are amenable to radiotherapy, but surgery is limited only to small 2A1. मतलब 1 में दे सकते हो, 1B में दे सकते हो, and small 2A1 तक कर सकते हो. Surgery क्या करोगे? You will do a radical hysterectomy. Okay, I'll just show you this पूरा table. ठीक है? So remember I said 1A1. Okay, you can even do a simple hysterectomy, but that's only if the biopsy report shows no lymphovascular space invasion. एक बार lymph nodes में चला गया, lymphatic spaces में चला गया, lymph nodes में नहीं, lymphatic spaces में चला गया, then you have to do your radical hysterectomy. Okay, what I said was the Wertheim's hysterectomy is type 2. If the patient wants to conserve her fertility, say she's a young lady, because remember cervical cancer has a bimodal age distribution. Matlab it happens in very commonly in the 30s and then in the 50s and the postmenopausal. So you see young women we see with cervical cancer, okay? And if their family is not complete and she has 1A1 or small 1A2 tumors, you can even do radical trachelectomy. इसका मतलब क्या है? आप सिर्फ cervix को निकाल रहे हो, uterus को नहीं. Cervix with paracervical tissue is called a trachelectomy. Okay, but it's not very commonly done. So radical hysterectomy, but 2A2 onwards, it is only chemo radiation. Okay, so the chemo radiation that we use, the chemotherapy which we use, this came in last FMG, is cisplatin. And the radiotherapy that we use, so cisplatin kya karta hai? It makes the tumor radiosensitive. So it's very important to give chemotherapy. So the day of chemotherapy or the day of radiotherapy, we always give cisplatin. Uske baad we give external brachytherapy, external beam radiotherapy. This is called as teletherapy. And then we give brachytherapy. Brachytherapy kya hai? This is so very close to the cervix, we give radiotherapy. So this is external and this is internal. We put internal rods inside the vagina and then we give the radiotherapy. So external and internal both are given. Teletherapy and brachytherapy both are given. And उससे पहले हम हमेशा देते हैं cisplatin. This makes the tumor more radiosensitive. Okay, so that is the end of cervical cancer. And now we move on to Mullerian anomalies. Okay, so Mullerian anomalies are important for the exam. It's a very high yield area. Usually one question comes, very commonly they ask imperforate hymen or this one. But let's discuss all of them in a little bit detail. Okay? So we start with MRKH syndrome. MRKH syndrome kya hai? Mullerian agenesis. Okay. Now before we go through here, just a bit about embryology. Okay, so when an embryo is formed, just a second, when an embryo is formed, okay, depending on the genetic sex, that means is it 46XX or 46XY, the further development takes place. Okay, if it is a 46XX, what is going to form? So till 5 weeks of gestational age, the gonads are अनडिफरेंशिएटेड मतलब 5 वीक्स पे हमें ये नहीं पता, वी कांट डू ऑन अ माइक्रोस्कोपिक एग्जामिनेशन, हमें नहीं पता चलता कि आर द गोनाड्स ओवरीज और आर दे टेस्टिस, सो दे आर अनडिफरेंशिएटेड. एट 5 वीक्स 46XX में the gonads will become the ovaries, and 46XY will, this is after 5 weeks, will become the testes. Now, in the 46XY embryo, which has the testes, what is going to happen? You're going to have the testes which has two cells, the Leydig cell and the Sertoli cell. Okay. Also remember that in this undifferentiated embryo, there are two ducts. Okay, you have two Mullerian ducts and two Wolffian ducts. ठीक है, Wolffian duct क्या बनाएगा? Wolffian duct बनाएगा मेल इंटरनल जेनाइटल सिस्टम को, और Mullerian duct क्या बनाएगा? फीमेल इंटरनल जेनाइटल सिस्टम को. ठीक है, so males, men are wolves, so you can remember that way. Wolffian duct is formed in the male and Mullerian duct is formed in the female. Okay, that's how I remember. Men are wolves. We're not really wolves, okay, but then just an easy way to remember. Okay, so what is happening in the Leydig, in the testes? ठीक है, testes, और ये सब हो रहा है embryo में. ठीक है, so embryo में at around 8 weeks, what is happening is that placental LH and HCG, they are stimulating the testes to secrete, the Leydig cells to secrete testosterone, and the Sertoli cells to secrete something called the anti-Mullerian hormone, also called the Mullerian inhibiting substance or Mullerian inhibiting factor. ठीक है, तो टेस्टोस्टेरोन क्या करेगा? टेस्टोस्टेरोन इस वुल्फियन डक्ट को डिफरेंशिएट करेगा. इट विल मेक द वुल्फियन डक्ट ऑफ दैट साइड. सो देयर आर टू गोनाड्स. एक साइड का गोनाड विल मेक दैट साइड ऑफ द टेस्ट ऑफ द वुल्फियन डक्ट ग्रो. The other side of the testes will make the other side Wolffian duct grow. So Leydig cells will secrete testosterone, and this will help in differentiation of the Wolffian duct. The AMH, what is the AMH going to do? The Mullerian inhibiting substance. The name itself tells you it's anti-Mullerian. It's going to cause the Mullerian duct to regress. ठीक है, तो 8 वीक्स पे ये हो रहा है. 8 वीक्स पे मेल इंटरनल जेनिटेलिया इज बीइंग फॉर्म्ड. हाउ इज इट बीइंग फॉर्म्ड? बिकॉज द टेस्टोस्टेरोन is making the Wolffian duct grow and the AMH is making the Mullerian duct regress. So your last FMGE exam, this question was asked, ki what does the Leydig cell secrete and what does the Sertoli cell secrete in the male embryo? Okay, now what is happening in the female? Okay, and at the same time, at 9 weeks, what is happening? 9 weeks पे क्या हो रहा है? जो testosterone हो रहा है. So till 9 weeks, till 8 weeks, the embryo is undifferentiated in terms of internal genitalia. Until 9 weeks, the embryo is undifferentiated in terms of external genitalia. So 9 weeks पे क्या हो रहा है? Testosterone is getting converted to dihydrotestosterone by an enzyme called 5-alpha reductase. ठीक है, और डाईहाइड्रोटेस्टोस्टेरोन क्या कर रहा है? इट इज मेकिंग द जेनिटेलिया, द एक्सटर्नल जेनिटेलिया, it is causing masculinization. That means virilization. That means it's making the male genitalia to form. ठीक है, now 46XX में क्या हो रहा है? 46XX में कुछ नहीं हो रहा है. ओवरी बन गया है. ठीक है, ना टेस्टोस्टेरोन है, ना एएमएच है, ना डीएचटी है. सो द डिफॉल्ट पाथवे फॉलो हो रहा है. डिफॉल्ट पाथवे क्या है? डिफॉल्ट पाथवे है फीमेल. So the woman doesn't need anything. The woman has everything she's got. The male is the one who needs the testosterone, who needs the AMH for it to grow. So females that way are set, है ना? नहीं है तो कोई जरूरत भी नहीं है किसी चीज का. They will follow the default pattern. And the default pattern is internal genitalia is Mullerian duct will grow and Wolffian will regress, and external genitalia is the normal female external genitalia. ठीक है, so this is what is happening in the embryo in very very basic terms, but this is what you need to know. ठीक है, अब Mullerian agenesis में क्या हो रहा है? The Mullerian, it is a 46, remember it is a 46XX embryo, okay, But for some reason, the Mullerian duct, so there are two Mullerian ducts, they grow and they gradually fuse like this and they form the uterus. Okay? So the Mullerian duct forms what all structures? This comes as a question. It forms the uterus, it forms the cervix, it forms the fallopian tubes, and it forms the upper part of the vagina. Okay, this is what it forms. So जब Mullerian agenesis होगा, incomplete agenesis, that is the MRK syndrome, all this is absent. Absent uterus, absent cervix, no fallopian tube, no upper vagina. Okay, and these girls are 46XX. But what is present? Ovaries are present. Okay, so ovaries present है, तो क्या होगा? Estrogen होगा. Estrogen क्या होगा? होगा तो the girl will appear normal. In the sense, at puberty, she will have secondary sexual characters. Breast development will be there, pubic, axillary hair, everything will be there. So she will present as primary amenorrhea. But क्या नहीं होगा? Menarche start नहीं होगा. So primary amenorrhea with secondary sexual characters. This is the presentation of MRKH syndrome. Okay, and when you do a karyotype, you'll find she's 46XX. Okay, remember that MRKH has associated anomalies, especially renal in 30% of these girls and skeletal in 15% of these girls. This also comes as a question. So if you have a girl coming to you with this presentation, secondary sexual characters present but period nahi aaya hai, the first thing you're going to look for, you're going to do an ultrasound or a clinical examination and look for the presence or absence of a uterus. Agar uterus absent hai, the next thing you're going to do is a karyotype. So this is the order you'll follow. And you will find if she's 46XX, you'll diagnose her as MRKH syndrome. Okay. Treatment क्या करोगे? How will you treat her? So there are two things. In fact, three things you're worried about. First thing is her mother will ask her, will she ever get her period? Answer is no, because uterus nahi hai. Second thing her mother will ask you is, how will she get pregnant? What is your answer? Your answer is she can't get pregnant herself, but you can use a gestational surrogate. That means you can use her eggs, and by IVF, you can transfer the embryo into somebody else's uterus. Okay? But there is a rare, increasingly common, I would say, not very rare now, uterine transplant can now be offered. It's still on experimental basis, but many have happened in India. So uterine transplant can be offered to this patient, and yes, she might get pregnant herself. Okay. And the third thing, which the mother may not ask you, but the patient at a later date might be worried, is sexual function, because she has a very small vagina. Okay. So the small vagina, how will she have penetrative intercourse? You have to tell her that you have to tell her parents that when she grows up and when she is at the age of getting married or sexual activity, you have to do what is called a vaginoplasty. Depending on the existing length of the vagina, you have to lengthen it either surgically or non-surgically using vaginal dilators. So तीन चीजें हैं. Periods नहीं आ सकते हैं unless maybe you do a uterine transplant. Pregnant हो सकती है through gestational surrogacy because she has eggs, she has ovaries, or you can offer her uterine transplant. And sexually, you have to do a vaginoplasty for her to be able to have penetrative intercourse. So this is Mullerian agenesis. All right. We'll discuss this again. Iska revision hoga in amenorrhea also. Okay. So if you've not understood or if you want a quick revision, we'll do it there again. Unicornuate uterus. This is the HSG picture. What has happened here is there are two Mullerian ducts. Only one has developed. The other has regressed. Regress होके या तो वो गायब हो गया या यहाँ पे एक rudimentary horn बन के रह गया. So you have only one functioning uterine cavity. The other may not be there, or it is formed what is called a rudimentary horn. Okay. HSG, it will look like this, one small uterus to one side. And typically, how do they present? They present with increased risk of, they present with infertility, increased risk of abortions. What else? They present with preterm labor because the uterus is small, तो वो hold नहीं कर पाता. Cervical insufficiency, preterm labor, fetal growth restriction, malpresentations. All these are common in most of the Mullerian anomalies. Okay. What do you do? So suppose, remember, अगर rudimentary horn के साथ patient है, then you should always excise the rudimentary horn. There is no other treatment for a unicornate uterus. You can't increase the size of this cavity. जो है वो है ना? So there's no surgical treatment unless there's a rudimentary horn. This needs to be removed, especially if it has functioning endometrium. If it has functioning endometrium, it's going to grow and grow and grow and form a hematometra, okay, which can cause painful periods. It can present as an abdominal mass. So this has to be excised. Okay. Otherwise, no surgical treatment to increase the size of the uterus. Second and the most common, third in fact, and the most common Mullerian anomaly is a septate uterus. So this is a hysteroscopic image of a septate uterus. ठीक है? Septate uterus presents with the same set of complications. Infertility. Why? Because ये जो septa है ये avascular है. तो embryo जाके यहाँ पे implant होगा, it will not grow. Okay. Second is abortions. Third is preterm labor. Fourth is fetal growth restriction. Fifth is malpresentation. So same thing. The cavity is small, it's restricted. There's less space. The baby is not able to grow, or it is in a malpresentation. It could be a complete septa, that means all the way down, or it could be a partial septa up till here. ठीक है. Normally क्या होता है, जब दोनों Mullerian duct fuse हो जाते हैं, they fuse by 20 weeks of fetal life. उसके बाद ये जो बीच वाला septa ये dissolve हो जाता है. So when there is incomplete dissolution of the septa, it forms a septate uterus. Diagnosis of all Mullerian anomalies, remember, can be done. Usually the first investigation we do is an HSG, but an HSG is not a very good method. फिर हम क्या करते हैं? We can do a 3D ultrasound or an MRI, which are much, much better investigations. In fact, the investigation of choice is an MRI. Some may differ with this. I know there's some controversy on which is the best investigation for Mullerian anomalies, but our standard gynae book still give this, that 3D scan is an upcoming investigation, but MRI remains the investigation of choice. Okay. But some anomalies like a septate uterus are in fact better diagnosed by a hysteroscopy or a hysterolaparoscopy, because actually seeing the anomaly rather than relying on imaging is sometimes better. तो septate uterus के लिए अगर कोई पूछता है investigation of choice, the answer is a hysteroscopy. And this is what you see on the hysteroscopy. If you see this, what will you do? Or a hysteroscopy with a laparoscopy. So बाहर से भी देखोगे, बाहर से आपको क्या दिखेगा? एक large fundus, broad fundus. अंदर से क्या दिखेगा? Septa. So what will you do? You will do this. What is this? This is a resectoscope. So with a resectoscope or even with the scissors, what will you do? You will cut the septa. What is called a hysteroscopic resection of the septa or a septoplasty. Okay, this is the treatment. Okay. I will come to the HSG images of all three, so don't worry. Okay. Next comes the didelphys. Didelphys, can you see what's here? They are two completely separate uterine cavities. कहीं पे भी connection नहीं है. You will see them completely separately. Many of the time they have their own services also. Okay. So when you do a speculum, you will see two cervixes. When you see two cervixes, you know there are two uteruses. Okay. And when you do a HSG, you may have to put in two Leach-Wilkinson cannula. It's not necessary, But most of the time, you will see two cervixes and you have to cannulate them separately to inject the dye. So you can see this is a beautiful HSG image of the didelphys. Important क्या didelphys में the same list of complications, infertility, abortions, preterm labor, FGR, and rarely malpresentations. But remember, didelphys usually has a good reproductive outcome. It is not as bad as the others. ठीक है, सो यूजली डायडेल्फिस में कॉम्प्लिकेशंस नहीं होते हैं, ना ही हमें ज्यादा कुछ करना पड़ता है, ना ही हम कुछ कर सकते हैं इसको. वी कांट जॉइन देम, दे आर टू सेपरेट यूट्रसेस. Also important in diadelphys is the O-Vera syndrome, which I've already explained. Obstructed hemivagina with ipsilateral renal agenesis, where you will find endometriosis. Not in all, only in a very rare population of diadelphys, you will find the O-Vera syndrome. What is this? This is a bicornuate. Bicornuate का मतलब क्या है कि दोनों horns join हो गए, but incomplete. So it's not, this has to fuse completely. The upper part has not fused. So this is a bicornuate uterus. Now, bicornuate uterus has the same set of complications, infertility, abortions, but very commonly you have cervical insufficiency and preterm labor, more commonly associated with bicornuate uterus. Okay. This is the HSG picture. Now this HSG picture, look how it is. Look at this angle. It's very important to see this angle. ये वाला. ठीक है, can you see how wide it is? If the angle is more than 105 degree on an HSG, it is more likely to be a bicornuate. But remember, HSG is a very poor investigation in terms of sensitivity to diagnose Mullerian anomalies. पर फिर भी वो एग्जाम में पूछते हैं, so you should know that if the angle is acute like this, it is a septate uterus. If the angle, this is less than 75 degree, if you actually want to measure it. If it is more than 105 degree, it is a bicornuate. दोनों के बीच में अगर हो तो confusion है. So these are usually true. If it's more than 105, it is more likely to be bicornuate. If it is less than 75, septate. And if they're two completely separate cavities with no communication whatsoever, it is a uterine didelphys. Okay, so this is the HSG pictures. Bicornuate में you can do surgical reconstruction. For example, patient comes with recurrent preterm labor or recurrent pregnancy loss or infertility. One thing you can do is you can do a laparoscopy. This is a laparoscopic image. So this is a laparoscopic image. Hysteroscopy से हम अंदर से देख रहे हैं, laparoscopy से हम बाहर से देख रहे हैं. And we excise this part and we join them together. Okay, so this surgery is called a metroplasty. That means repairing or joining the two horns of the uterus. Okay. Next are the obstructive wale, imperforate hymen and transverse vaginal septum. Till now we were discussing longitudinal defects. Now we're discussing transverse defects. So what happens in embryology? Once the Mullerian duct fuses, the upper part of the vagina is formed by the Mullerian duct and the lower part by the urogenital sinus. Both fuse and then this septa will dissolve. So if this septa fails to dissolve, it forms what is called a transverse vaginal septum. Now this TVS can be low, it can be mid, or it can be high. ठीक है, जो low वाला है, it very commonly presents as very similar to an imperforate hymen. ठीक है, because obstruction नीचे की तरफ है. So how will this patient present? She will present with primary amenorrhea with cyclical abdominal pain because she is having her period. ऐसा नहीं कि blood नहीं आ रहा है, bleeding हो रहा है, but it is collecting here. It's not able to come outside. So it's collecting. So initially she's going to have hematocolpos, that means blood in the vagina, and then she's going to have hematometra. Okay, then she's going to have hematosalpinx, and then she's going to have endometriosis. endometriosis. This is what is going to happen if you don't relieve the obstruction. How will you diagnose this? तो मैंने बताया imperfect hymen जैसे present करेगा, but imperfect hymen में हमारा classical buzzword क्या है? You'll see a bluish bulge at the hymen. इसमें वो बल्ज नहीं दिखेगा, क्यों? क्योंकि सेप्टा थिक होता है. तो इवन इफ अ लॉट ऑफ ब्लड कलेक्ट्स हियर, इट वोंट यूजुअली बी एपरेंट ऑन अ लोकल एग्जामिनेशन. लोकल एग्जामिनेशन पे आपको ब्लाइंड वेजाइना दिखेगा, आपको और कुछ नहीं दिखेगा. सो इफ यू आर सस्पिशियस ऑफ अ टीवीएस, डू एन एमआरआई. MRI is the investigation of choice. It will tell you the level of obstruction also. And treatment क्या करोगे? You're going to excise the septum. Under anesthesia, you're going to cut off this septum, पूरा excise करोगे, ठीक है? And then usually we have to line the vagina with a graft ताकि दोबारा वो बंद ना हो जाए. Okay? Imperfect hymen is more commonly seen. It's more easier to treat because just the hymen is imperforate. So this will present similarly, primary amenorrhea with cyclical abdominal pain. इसको क्या कहते हैं हम? इसको हम कहते हैं cryptomenorrhea. Crypto मतलब hidden periods, है ना? So but the same thing will happen. Hematocolpos, hematometra, hematosalpinx, endometriosis. ठीक है? And many times these girls with either this or this. Another common presentation could be retention of urine with an abdominal mass. तो वो हेमाटोकॉल्पोस या हेमाटोमेट्रा इतना बड़ा हो जाता है, it puts pressure on the neck of the bladder. It causes her to go into acute retention, and when you examine her, you find an abdominal mass. This is another presentation, possible question that can come in the exam. ठीक है? Because every year they try to change the way they ask this. So the bluish bulge at the hymen, and it's usually diagnosed on clinical examination. You don't usually need an MRI, but if in doubt, you can get an MRI done. And treatment क्या है? Treatment ये जो imperforate hymen है, यहाँ पे you put an incision called the cruciate incision, मतलब cross shaped incision. So you get 4 flaps, and then you suture this flap here, this here, this here, this here, and जितना भी blood अंदर है वो drain हो जाता है बाहर. So this is for the treatment of imperforate hymen. Remember this. All these are buzzwords, everything that I've written here. Next, coming to primary amenorrhea. Now, primary amenorrhea के important points है. सबसे पहले definition. ठीक है? Primary amenorrhea बहुत important topic नहीं है FMG के लिए, but एक आधी बार question आ जाता है. So I thought I'll just spend a few minutes on this because recently questions have started coming. Okay, so in the apps, the definition of primary amenorrhea is if a girl comes to your OPD, usually the question comes, a mother brings her daughter to the OPD, and she is 13 years old, and you examine her and you find no secondary sexual characters. वो कहती है periods नहीं start हुए, and when you examine her, you find no secondary sexual characters. That is one definition. ठीक है? Because by the age of 13, you expect कि at least breast development would have started. That is thelarch. Thelarch is breast development. Then that is followed by pubarch and then menarche. But breast भी develop नहीं हुआ है by 13 years, you are worried and you will define her as primary amenorrhea. The second definition is 15 years with the presence. So suppose she comes at 13 years and she has secondary sexual characters. You examine her breast development, looks good. There is some pubic hair, some axillary hair. So you tell her mother, nothing to worry. अगर 2 साल में भी नहीं आते, 2 साल और वेट करो, ठीक है? Then if she still doesn't get her period, then we'll see. So 15 years in the presence of secondary sexual characters is called as primary amenorrhea. This is the second definition. Okay. So 2 definitions, what are they? In the absence of secondary sexual characters, no period, or in the presence of secondary sexual characters by the age of 15 years. A third definition, which is a more recent definition, is thelarch has happened. That means breast development has started. So usually within 2 years of breast development, you expect her to get her period. So no menarche even after 3 years of thelarch is called as primary amenorrhea. So 3 years ke baad bhi, if she's not got her period, 3 years of starting of breast development, that is a third definition which is now included in the list of definitions. This was earlier 14 and 16, but most guidelines have now changed this to 13 and 15. ठीक है. नाउ जब हम बोलते हैं ना सेकेंडरी सेक्सुअल कैरेक्टर्स नहीं है, इसका क्या मतलब है? व्हाट डज दिस मीन? दिस मीन्स दैट देर इज नो एक्सपोजर टू ईस्ट्रोजन. सो दिस is the first thing we see when we say primary amenorrhea. The next thing you should look for in the question is the presence or absence of secondary sexual characters. So this is what we're going to discuss. Just two flowcharts on how to approach a patient of primary amenorrhea. The first thing is she has normal secondary sexual character. So she's come with primary amenorrhea by definition, okay? And your question says that there is normal secondary sexual characters, okay? Then what do? Then the next thing you will look for, I've discussed this before also, is either you do an examination or do an ultrasound and look for the presence or the absence of a uterus. So primary amenorrhea, first thing आप देखोगे, question में क्या दिया हुआ है? Secondary sexual characters are there or not there? If they are there, you're going to follow this flow chart. This flow chart says the first thing you're going to look for is the presence or absence of a uterus. Now, if the uterus is present, secondary sexual characters are present, uterus is present, everything looks normal, then what should you think of? You should think of your obstructive anomalies. कि कहीं imperforate hymen या TVS तो नहीं है. So is she having cyclical abdominal pain? Is there a bluish bulge? So look for an obstructive anomaly. अगर ये rule out हो गया, then if the anatomy is normal, then it most likely is constitutional. Constitutional का मतलब it is genetic. Wait for a few more months or years, she'll get her period. So you don't have to worry too much or think of some hormonal disturbance like early PCOS or high prolactin levels, but this is what it normally is. That means there is no problem. Normal secondary sexual characters present, uterus present, no outflow obstruction, it is mostly constitutional. Problem aati hai when the absent uterus is absent. So you have secondary sexual characters, but the uterus is absent. What should you do next? You should do a karyotyping. Okay. If it is XX, what are you thinking of? You are thinking of what we just discussed, that is MRKH syndrome or Mullerian agenesis. Okay, this is your definition. This is your diagnosis. The problem comes if it is 46XY. Suppose all this is there and it is 46XY. Then you will think of something called complete AIS, complete androgen insensitivity syndrome, also called as testicular feminization syndrome. What is happening here? Here, in fact, secondary sexual characters are there, but if you look at the history more carefully, you will find that there is only breast development. Pubic and axillary hair are absent. Okay. What is happening in these individuals? They are 46XY individuals. They have testes. The gonads are testes. But the testosterone is not acting. There is an insensitivity to the androgen. So because the testosterone is not acting, there is no Wolffian duct. The Mullerian duct has regressed because AMH था, Mullerian duct regress हो गया, but Wolffian duct grow नहीं कर पाया because testosterone नहीं act कर पा रहा because of the insensitivity. Okay. So at puberty, what's happening? You think they're girls because why is there breast development? Because there is some androgens are not acting where they should, but androgens start getting converted to estrogen. And this estrogen is acting on the breast. So breast development will be there. They look like girls, okay, and they're brought by their mothers because external genitalia is female. There's no testosterone. I told you, na, जहाँ पे testosterone नहीं है but act नहीं कर रहा है. So that will follow the default pathway of a girl. Okay, but Mullerian duct is absent because of the anti-Mullerian hormone. Okay, so this is how they'll present. Absent uterus with breast development with 46XY. Your diagnosis is androgen insensitivity syndrome. Okay. Next group of girls, primary amenorrhea. The question will tell you she's primary amenorrhea with no secondary sexual characters, no breast development, no pubic hair, no axillary hair. What's the next thing you will see in your question? You'll see कि height क्या दिया हुआ है, short दिया हुआ है या नहीं. Short दिया हुआ है. What's the first thing you're going to think of is Turner syndrome, because Turner syndrome is the most common cause of primary amenorrhea, number one. And number two, all Turner girls, all of them are short in height, because the sign canon, that means सबको ये feature होगा, of Turner is short height. All Turner girls are short. ठीक है. So short word अगर आपको दिख रहा है, it is a buzzword telling you that this is Turner syndrome. And Turner syndrome is very commonly asked in the exam. But how can we still confirm कि कोई और reason तो नहीं है short height का? Maybe growth hormone is less. We do a FSH level. ठीक है. FSH हमें क्या बताएगा? FSH हमें ये बताएगा कि प्रॉब्लम ओवरी में है. बिकॉज टर्नर में प्रॉब्लम कहाँ है? टर्नर में प्रॉब्लम है ओवरी में. देर आर स्ट्रीक ओवरीज. द ओवरी इज नॉट फंक्शनिंग. That's why there are no secondary sexual characters. So if the FSH levels are high, that means the problem is in the ovary. But if the FSH levels are low, that means the problem is upper, hypothalamic pituitary area. So FSH level is a very good level, a good test to tell us where the problem is in whenever the secondary sexual characters are absent. ठीक है. तो suppose the question says कि absent characters, height is normal, तब भी हम FSH ही करेंगे next. क्यों? क्योंकि हमें तब भी देखना कि प्रॉब्लम ओवरी में है या हाइपोथैलेमिक पिट्यूटरी में है. So Turner's is a form of gonadal dysgenesis, remember, okay, but it is in a 45XO karyotype, and the girl is short. If the girl is normal in height and the FSH is high, the problem is still in the ovaries, but it is not Turner's. There are other types of gonadal dysgenesis also, which are called as 46XX or 46XY gonadal dysgenesis. Here, इधर भी क्या हो रहा है? The gonads are dysgenetic. They have not formed properly. And as a result, these girls have primary amenorrhea with absent secondary sexual characters. Okay, इसमें जो 46XY वाला type है, this is called as Swyer syndrome. You can remember this as being 46XY. Y for Y. Swyer is always 46XY. And these have a uterus. Uterus is present because the AMH, the gonads are dysgenetic. So जो AMH is not being produced, the uterus doesn't regress, Mullerian duct doesn't regress, Mullerian duct and Wolffian duct दोनों ही बन जाते हैं. सॉरी, वुल्फियन डक्ट नहीं बनेगा इसमें, बिकॉज टेस्टोस्टेरोन भी नहीं है, AMH भी नहीं है. सो इट विल टेक द डिफॉल्ट पाथवे, दैट इज द Mullerian duct will grow, external genitalia will be female. Okay, and all that is happening because although the gonads, the testes are there, but they are dysgenetic, so they are not secreting any hormone. So they are 46XY with a uterus is Swyer syndrome. 46XY without a uterus is androgen insensitivity. Remember, जहाँ पे Y है वो 46XY है. तो androgen insensitivity is 46XY and it is without a uterus. Swyer is 46XY. Okay, but Swyer is with a uterus. Okay, because AMH और testosterone दोनों ही नहीं है, तो default pathway goes towards being a female. Okay. So this is what you should know from your exam point of view. As I said, in the recent past, only 1 or 2 clinical questions have come on primary amenorrhea. That's why I'm not spending too much time on this. Next comes secondary amenorrhea. Secondary amenorrhea means absence of periods for more than 6 months. Here the causes could be Asherman syndrome. What is Asherman syndrome? Asherman is intrauterine synechia. That means intrauterine adhesions. Typical history क्या? There will be a history of DNC. Vigorous curettage, endometrium destroy हो गया. adhesions ban gaye, the patient doesn't have her period. Or there could be a history of genital tuberculosis, which also causes endometritis and destruction of endometrium. So in Asherman, typically your hormone levels are going to be normal because the problem is not in the HPO axis, hypothalamus pituitary ovary, ठीक है. Problem का है? Problem है uterus में. Okay. Next could be ovarian. Ovarian mein we should think of two things in secondary amenorrhea. One is PCOS, okay, that is an ovulation. Ovulation is not happening, that's why she's having amenorrhea. The second thing we should think of is premature ovarian failure, which will cause premature menopause. So menopause happening before the age of 40 years is called as premature menopause. हो क्या रहा है इसमें? The ovaries have stopped functioning much before they should have. Okay, so that's premature ovarian failure. Here the FSH is going to be high. जैसे menopause में क्या होता है? FSH high हो जाता है. इसमें भी premature menopause में भी FSH is going to be high and estrogen levels are going to be low. PCOS में what's going to happen? The typical hormonal profile is the LH to FSH ratio is going to be increased. Normally, LH is less than FSH, but in PCOS, LH increases. So LH is higher than FSH in PCOS. In pituitary causes, what is the main thing we think of is Sheehan syndrome. Okay, and here there's a typical history of excessive bleeding at delivery और PPH. ठीक है, उसके बाद क्या हो जाएगा? The pituitary gets necrosed. And as a result, all the hormones secreted by pituitary will go down. So you'll find failure of lactation, you'll find a patient feeling tired, fatigued, there'll be secondary amenorrhea. So all these symptoms will go together. So these are the three main or four most important causes: Asherman, PCOS, premature ovarian failure and Sheehan. Sheehan में क्या होगा? FSH and LH दोनों ही कम हो जाएंगे. ठीक है? So by the hormone patterns, you know what you are dealing with. So that's very important to understand कि problem क्या है. Question कैसे आएगा? कोई clinical question आएगा and they'll give you some clues and they may give you the hormone values and you should know how to interpret them. So what is the most common cause of secondary amenorrhea? The answer is pregnancy. एक FMG paper में आया हुआ था कि unmarried girl presents with secondary amenorrhea. 18-year-old unmarried girl presents with secondary amenorrhea. What is the next best test? The first thing you should do, even if she is unmarried, remember marriage is not a prerequisite to get pregnant. Okay, so pregnancy can happen in unmarried girls also. फिर सबसे पहले आपने pregnancy test करना. You have to do a UPT. That's the most common cause of secondary amenorrhea. Okay. So do a UPT. Also rule out high prolactin levels because hyperprolactinemia can cause secondary amenorrhea and thyroid disorders can also cause secondary amenorrhea. If these three are ruled out, okay, then what should you do? Then you should give what is called the progesterone challenge test. ठीक है, इसमें क्या करते हैं हम? प्रोजेस्ट्रॉन देते हैं पेशेंट को. यूजली वी गिव इट फॉर अराउंड 7 to 10 days and then we see whether she's bleeding or not. So there are two possibilities. Ki one is she bleeds, one is she doesn't bleed. So on giving progesterone, if she's bleeding, what does that leave us? What is our diagnosis? That means she's having an ovulation. Because an ovulation में progesterone की कमी होती है. The ovulation hasn't happened, the corpus luteum hasn't formed, there is no progesterone, so she's not bleeding. But if by giving progesterone she bleeds, that means she's having an ovulation, and the most common cause of anovulation is what? PCOS. Okay. Now, if there's no bleeding on giving the progesterone challenge test, what do? We give estrogen plus progesterone. Ki maybe estrogen ki kami hai. That's why she's not bleeding. So we give a packet of combined OC pills, 21 tablets. This contains both estrogen and progesterone. and we see if she bleeds or not. So there are two possibilities. Either she bleeds or she doesn't bleed. Now, if she bleeds, that means there is some deficiency of estrogen somewhere. So what should we do? How do we know where the problem is, in the ovary or higher up? Our FSH will tell us कि problem कहाँ पे है. If the FSH is low, the problem is in the pituitary or the hypothalamus. If the FSH is high, the problem is in the ovary. And what is this? Premature ovarian failure. और अगर low है, then think of maybe something like Sheehan syndrome or some other hypothalamic pituitary cause. And if there is no bleeding on giving E plus B also, मतलब E पे भी bleed नहीं किया, P पे भी bleed नहीं किया, that means everything must be fine. The problem is lying in the uterus. And that is when you start thinking of Asherman syndrome. Okay, so this is the flow chart for secondary amenorrhea. This is basically just telling you how to again arrive at the cause based on the history, based on the clues given. But remember, the first thing is always rule out pregnancy. उसके बाद बाकी चीजें सोचना शुरू करो. Okay. Now, very common asked question, PCOS. PCOS को कैसे हम diagnose करते हैं? What is PCOS? PCOD, same thing. Okay, confused नहीं होना. PCOS and PCOD are same thing. Rotterdam criteria. So 2 out of 3 criteria. First is hyperandrogenism, that is clinical or biochemical. Clinical, they'll give you history of acne, history of hirsutism, and biochemical, they will give raised testosterone levels. Okay, these are your clues for hyperandrogenism. Menstrual irregularities. This is usually oligomenorrhea. That means delayed cycles. So history will be she gets her periods once every 2-3 months. Okay. Oligomenorrhea. And third is ultrasound features of polycystic morphology. इसका क्या मतलब है? इसका मतलब है ये वाला पिक्चर. ठीक है? This is called a string of pearls or necklace pattern. Okay, so what's happening? You have an enlarged ovary. They're large ovaries with a lot of central stroma. Okay, in fact, these ovarian volume is more than 10 centimeter cube. And the follicles, you have the small follicles arranged in the periphery. So, any two of these, zaruri nahi hai ki you have to have the ultrasound feature. You can have just acne and delayed cycles, then also she's PCOS. Okay, or you have polycystic ovaries with hirsutism, then also she's PCOS. So zaruri nahi hai ki every patient will have oligomenorrhea, zaruri nahi hai every patient will have this picture on the ultrasound. So 2 out of 3 have to be there. Now, when it, forget this, okay, this is not supposed to be there. Treatment of PCOS basically depends on the question that is asked. Remember, the primary thing is lifestyle measures. Okay, lifestyle measures are your primarily thing because many of these girls have an increased BMI. So you have to lower their BMI. Even if their BMI is normal, you have to tell them to get on a good diet and exercise regime. तो चाहे उसका कोई भी प्रॉब्लम है, चाहे उसको एक्ने है, हर्सुटिज्म है, ओलिगोमेनोरिया है, एंड बिकॉज ऑफ दिस ओलिगोमेनोरिया शी विल हैव इनफर्टिलिटी, शी इज हैविंग एन ओव्यूलेशन, शी इज नॉट एबल टू कंसीव. So irrespective of her symptom, you have to advise lifestyle measures. So this has to be there in your answer. Okay, so if the question comes, patient has an ovulus, she's having infertility, diagnosed PCOS, what will you do? So always look for an option which also has this. Okay, because your primary goal is also not only to treat her problem, you will treat her problem. What I mean to say is your primary treatment will include lifestyle measures also. By losing weight, she will start ovulating herself. You may not even need to give her medicine. Okay. So lifestyle measures is going to be 50% of your treatment plan, and the remaining 50% depends on her symptom. Okay. So let's start with infertility. So your question comes, infertile woman with PCOS. The first thing you're going to do is lifestyle measures. You tell her to lose weight. If she's still not able to conceive, then you give her drugs. Okay. And because she's having an ovulation, you will give her ovulation induction drugs. Now, the drug of choice for ovulation induction in PCOS is not clomiphene. Okay. It is letrozole. ठीक है, but we'll discuss both of them. पहले हम clomiphene देते थे. Now we give letrozole for PCOS. It is the drug of choice. This has come as a question many times now. Clomiphene citrate क्या करता है? It is an anti-estrogen. So it's going to suppress the estrogen levels. This will give a positive feedback on the hypothalamus pituitary. So FSH, LH levels are going to go very high. And this is going to recruit more follicular development in the ovary. Okay, so it's going to cause a multi-follicular ovary. ठीक है, so बहुत सारे follicles grow करने लग जाएंगे and hence the chance of pregnancy increases. Not only pregnancy, there is a risk of multiple pregnancy now. कल हमने पढ़ा ना, multiple pregnancy IVF में भी होता है, ovulation induction में भी होता है. ठीक है, so that's the downside of clomiphene. It increases the risk of twins and triplets and even quadruplets. Okay. But it is very good because 80% of patients will ovulate. If she's having an ovulation, just by giving clomiphene, 80% will start ovulating. Okay. Now, the second drug and the drug of choice actually is letrozole. Letrozole, remember, is an aromatase inhibitor. Aromatase inhibitors क्या करते हैं? Aromatase क्या करता है? Estrogen it is the enzyme responsible for formation of estrogen. So if this is absent, estrogen levels are going to go down. Same thing, FSH, LH is going to increase, but it's not that strong as clomiphene. So this is going to recruit follicles, but only one follicle. So monofollicular development. So it's a more controlled ovulation induction agent because only one follicle. और हम यही चाहते हैं कि one ही follicle बने. We don't want multiple follicles because we don't want her to have twins or triplets. Okay. Because that's a high risk pregnancy. Not because we're being mean. We just want her to have one safe pregnancy. Okay. Not a high risk pregnancy. ठीक है, तो monofollicular development होगा and she will ovulate. Okay. So this is letrozole. Okay. Dose क्या है? 2.5 milligram from day 2 to day 6 of the cycle. क्लोमिफिन का डोज क्या है? 50 milligram from day 2 to day 6 of the cycle. ठीक है, you can increase this to 150 milligram. You can increase this to 5 milligram. Nowadays they say you can even increase to 7.5 milligram. ठीक है, if she doesn't ovulate, keep increasing the dose every cycle. Okay. Now this is the second line drug. Suppose clomiphene doesn't work, suppose letrozole doesn't work, फिर हम क्या कर सकते हैं? We can directly give her FSH injection. So FSH injections are available in the market. Directly give her FSH. Okay. Or you can give HMG. HMG injections क्या होते हैं? Human menopausal gonadotropins. ये क्या contain करेगा? This is a mixture of FSH plus LH. तो प्योर LH नहीं मिलता है, FSH मिल जाएगा, HMG मिलेगा. I'm just telling you this HMG because this has come as a question previously कि woman was given HMG. So you should know what is HMG. It is human menopausal gonadotropin. It is obtained from the urine of menopausal women. मेनोपॉजल वुमेन में यूरिन में क्या हाई होगा? LH और FSH हाई होंगे. तो it is extracted from there, purified and then given to these women, and this will cause ovulation. Okay. Suppose this also doesn't work, then another second line management is this laparoscopic ovarian drilling. That means we drill holes in the ovaries. ठीक है, 4 holes in one ovary. That means total 8, है ना? And this will cause ovulation in those patients who are resistant to drugs. So in 50% of patients who undergo drilling, you will find ovulation. Basically, क्या कर रहे हो? You're reducing the bulk of the ovary. Okay, the ovarian volume कम कर रहे हो, and that causes ovulation to happen. ठीक है? And the last topic for the day is contraception, because this is a very important. I mean, I have seen amongst INI, NEET PG and FMG में ही सारे सबसे ज़्यादा questions are asked on contraception. Okay. So we will spend some time on this. Okay. Now classification, you all know we won't go into that. Important. So in classification, what I meant to say was the first is natural methods. Natural methods में सबसे important है lactational amenorrhea method. Okay. The LAM method is basically you're advising a woman who is lactating that the chance of her having ovulation is very, very minimal because of high prolactin levels. So this has come as a question. What is inhibiting ovulation in the lactational period? It is high prolactin levels. Okay. And this is used to take advantage of this fact that we can advise a woman who is number one, exclusively breastfeeding. Number two, a woman who is amenorrheic, that means she's not got her period. And number three, her baby is less than 6 months old. If all three criteria are met, this is called the Bellagio criteria. If all three are met, then she has a very less chance of conception. So you can use this method as a contraceptive method. If all the three criteria are met. So this is called the Bellagio criteria. All three have to be met to use it as a contraceptive method. To tell her that your chance of conceiving is very, very less. Next important are the intrauterine devices. So you have three generation of devices. The first generation, which are no longer used, are the unmedicated. Just a second. Okay, so first generation are the unmedicated copper teas. Okay. And this is a lipase loop. And when they were first introduced, so there's no medication on them. They simply act like a, they avoid the sperm from ascending upwards. Okay, then second generation is the copper containing intrauterine devices. And the third generation are the LNG, that means the progesterone containing devices like the Mirena. Okay, and all these two are very important to know. What is this? This is the copper T380A. ठीक है, A क्यों है? Because arms पे भी copper है. These are the arms. The arms also have copper. The stem also has copper, and the total surface area of the copper is 380 millimeter square. Okay. It's available in this packet. You can see it's available here. And when we put the copper tea inside, remember the arms are to be put inside this plunger. Okay, and inside the cannula. And this is done using a no touch technique. मतलब plastic को wrapper को खोलने से पहले ही we put the arms inside and then only we open the wrapper. Okay, so it's called a no touch technique. And we introduce it inside using the withdrawal method. So remember these two terms, no touch and withdrawal. यहाँ पे थोड़ा सा bulge होता है. ये bulge क्यों होता है? To prevent uterine perforation when we are inserting the copper T. And you have a thread which is seen here. Okay, and this thread which is seen here is so that we are able to check the position of the copper T when she comes for a follow-up visit. Now it's 380. So 80 में 0 है. So its का lifespan है 10 years. That means this is the upper limit. It can be kept for a duration of 10 years as against this one. This is copper T 375, also called the multi-load. तो इसमें आर्म्स पे कॉपर नहीं है, इसलिए ए नहीं है. इट्स कॉल्ड दी सेरेशंस and this helps it to remain inside or in place because it fixes to the endometrium using the serrated edges. And because यहाँ पे 5 है, इसका duration of use is 5 years. Okay. So this is copper T380A, copper T375, and both of these are available by the government of India. Both are available freely. And important to know is when can you insert the copper T? Now, copper T can be inserted during different times. The first one is related to delivery. So what is called as postpartum insertion. Okay? So postpartum insertion can be early और लेट पोस्टमार्टम इंसर्जन मतलब 4 वीक्स के बाद. WHO कहता है 4 वीक्स के बाद, गवर्नमेंट ऑफ इंडिया कहता है 6 वीक्स के बाद. ठीक है. और इट कैन बी अर्ली कुड बी पोस्ट placental, that is PPIUCD. This is within 10 minutes of placental delivery. मतलब थर्ड स्टेज जो फोर्थ स्टेज ऑफ लेबर है ना, उसके पहले 10 मिनट में if the woman is willing, you can insert the the intrauterine device, and this is inserted using something called a Kelly's forceps. It's a lumbar instrument without a lock, okay, without a latch at the end. It can be used to insert the copper T. Okay. The other time is intra-cesarean. So during the time of cesarean also you can put the copper T. And the third is within 48 hours. So 10 minutes se leke 48 hours tak. If you go to the ward the next day and the patient says, can I still get a copper T? You tell her yes. So 48 hours of insertion also. So these are the times of early copper T insertion. Okay. And both copper T 380A or 375 can be used for this. लेट का मतलब 4 वीक्स के बाद या 6 वीक्स के बाद. But between 48 hours and 4 weeks, it is and not to be put. Okay, it is not to be put during this duration in between. Okay, the second time you can put is interval. Interval means not related to delivery. So you can put it at any time during any time, okay? Except that you should be reasonably sure that she is not pregnant. So it's always better to put it post menstrually, but it's not necessary. You can put it in any time of her menstrual cycle, just as long as she is reasonably sure that she is not pregnant. Agar doubt hai, then call her post menstrually. And the third time you can put it is post-abortal. If she's just had an abortion, first trimester or second trimester, you can put in the copper T. And one more time you can use it is as an emergency contraception, okay, within 120 hours or 5 days of unprotected intercourse. Okay, so this is very useful in those women who want a prolonged method of contraception, and they come to you and you can counsel them, especially if she's 120 hours of unprotected intercourse. Now, this slide is very, very important. So you should know the absolute contraindications of the contraceptive devices. Absolute contraindications of an intrauterine device, this is including Mirena, is what all? So you can't get pregnant. Pregnancy, that means not, of course, pregnancy basically means suspected pregnancy. And now you should not put a copper T. You cannot get pregnant if you have an IUCD. Infection ka matlab kya hai? Infection means any active pelvic inflammatory disease, any puerperal sepsis. Say you want to do it in the puerperal period, but she is having fever, endometritis, discharge within 48 hours. Okay, or if she's had post-abortal sepsis, or if she has genital tuberculosis, any infection basically, you should not put in a copper T. Or if she has U is what? Undiagnosed genital bleeding. So she's having AUB, but you don't know what the reason is, then don't put in a copper T. C is what? Malignancy. Which malignancy? Cervical, endometrial, and choriocarcinoma. You will not put in a copper T. And D is distorted cavity. That means a Mullerian anomaly. Uterine didelphys, you're not going to put in a copper T. or she has a large fibroid distorting the cavity, or she has a submucosal fibroid, तो cavity के अंदर कुछ है, you will not put in a copper T. So these are the absolute contraindications. You can't get pregnant if you have an IUCD or PIUCD, you can remember. Okay. Now coming to hormonal contraception. In hormonal contraception, we basically have two types. You have the combined estrogen plus progesterone and you have the only progesterone. जो combined E plus P है, we mainly have three. We have the pill, we have the patch, and we have the vaginal ring. Okay, and what is the mechanism of action in all of them? This is inhibition of ovulation. So ovulation inhibition. That means by giving estrogen and progesterone, you are inhibiting ovulation from happening. And only progesterone, what all can you give? You can, it's available as progesterone only pills, also called the mini pill. It's available as an injection, depot-medroxyprogesterone acetate, Antara. It's available as implants. Okay, and it's available as Mirena, LNG IUD. और इसमें मेन मैकेनिज्म ऑफ एक्शन क्या है? I've already told you, endometrial atrophy, and also second one is cervical mucus thickening, and this is preventing the sperm from coming up. Okay, so endometrial atrophy is the primary one, also cervical mucus thickening. ये दोनों इसमें भी हैं, but इसमें primary ovulation inhibition is the mechanism of action. So when we talk about combined pills, this is the one in red. This is the primary mechanism. बाकी सब भी हैं, but primary, if it's asked and it has been asked, the answer is ovulation suppression. What are the absolute contraindications to the combined OC pill? So remember, here we are using estrogen. Estrogen is very bad for two things. Estrogen is very bad for thromboembolism. So if there's a history of DVT, or there's a history of stroke, or there's a history of prolonged immobilization, or if she's smoking more than 15 ciggies per day, okay, all these increase her risk for thromboembolism, so you will not give estrogen, okay. Or if she is, also estrogen is bad for what other thing? It's bad for breast. It causes breast cancer. तो history of breast cancer है तो नहीं देना है, ठीक है. Also it's bad for those girls who have migraine. So if there's a history of migraine with aura especially, तो नहीं देना है, ठीक है. And if there's a history of uncontrolled, it will come here only because it increases the risk of thromboembolism. History of uncontrolled hypertension or history of ischemic heart disease. So all these increase the risk of thromboembolism. You will not give combined estrogen plus progesterone pills mainly because of this one, which is the bad thing, estrogen. Okay. Also remember, very important, should we give OC pills, the combined OC pill in breastfeeding women? Remember, if she is less than 6 weeks, it is absolutely contraindicated. So I'll write it here. History of breastfeeding and less than 6 weeks. Why? Because pregnancy is a hypercoagulable state and pregnancy के effects रहते हैं till the puerperium, है ना? So puerperium also is a hypercoagulable state. There's an increased risk of thromboembolism. So if she is breastfeeding, even if she's not breastfeeding, so I will put this as puerperium. That means 6 weeks after birth, irrespective of breastfeeding status, you will not give the combined pill. Now, in a breastfeeding woman, less than 6 weeks, we know it is absolutely contraindicated, right? Even 6 weeks to 6 months, that means 6 महीने तक भी, it is relatively contraindicated. Why? Because it affects the quality and quantity of breast milk. So you should not give it. The risks outweigh the benefits. So it should not be given. Okay, so less than 6 months nahi dena hai. But after 6 months, you can safely give the OC pill even if she is breastfeeding. Because now the benefits outweigh the risks. 6 months ke baad, you anyway, the woman will start weaning her child. Okay, so after 6 months, if she wants to take the pill, she can take the pill. Okay. Now, again, a very, very important slide. I've already told you this, but just quick revision. It increases the risk of breast cancer and to some extent cervical cancer. It decreases the risk of CEO, colorectal, endometrial, and ovarian cancer. Okay, very important. The same thing happens if you're giving hormonal replacement therapy in the menopause. So HRT जब देते हैं menopausal age group में, remember HRT is going to increase the risk of breast cancer, but primarily reduces the risk of colorectal cancer. Endometrial ovarian बहुत ज़्यादा important नहीं होते हैं. ये दोनों for HRT you should remember. Okay. Vaginal ring, same thing. What is the content? It contains, so remember, जो भी हम ये estrogen plus progesterone कुछ भी दे रहे हो, pill, ring, patch, the estrogen component remains the same. Ethinyl, estradiol is the estrogen component. So ring में भी EE होता है, plus progesterone is etone or gestrel. Okay. With the ring, remember that the ring is worn for 3 weeks and then gap of 1 week. She removes the ring and then next cycle she uses a new ring. Okay. With the pill, we give 21 days of the tablet. That means 3 weeks and then 1 week gap, then 3 weeks and 1 week gap. That's how we give the pill. With the ring, we give it for 3 weeks. She wears it for 3 weeks. Here we're taking one pill every day. With the ring, she's wearing the same ring for 3 weeks and then she takes a 1 week gap. Okay, in that 1 week gap, she'll get her period. In this 1 week gap, they get the period and then they start a new packet or a new ring. The patch contains ethinyl estradiol plus the progesterone is norelgestromin. Okay, and the patch is 1 week, every week a new patch. So 1 week plus 1 week plus 1 week, and then a gap of 1 week. So every week a new patch has to be put. With the ring, every 3 weeks, one ring lasts for 3 weeks. With the patch lasts for 1 week. Next, coming to the progesterone only. Here, what is important is that this one. This is DMPA, also called Antara, freely available by the government of India. It's a 150 milligram deep intramuscular injection, okay, which is to be given once in 3 months. The side effect or the disadvantage, biggest disadvantage of this is it causes a delayed return to fertility. मतलब patient को अगर she takes this and then she stops it and because she wants to plan her second child, you have to counsel her that it takes 6 to 12 months for ovulation to resume. Okay, it takes a very long time for ovulation to come back. So this has to be clearly told to her. Also, it causes a lot of irregular bleeding and she can even have amenorrhea. Okay, so that's another side effect. But the good thing is it is very, very effective. Implants, what should you remember about this? You have different implants. You have 1 year, 3 year, 5 year implants. India में available नहीं है, ठीक है, इसलिए ज़्यादा questions नहीं आते. But सबसे important ये है, it is the, in fact, is very, very effective. In fact, it is the most effective temporary contraceptive. So if somebody asks you which is the most effective contraceptive and आपके choice में implant है, तो answer is implant. Okay, it's available by the name Implanon. Jadel, Norplant, these are the common names it's available with. Again, it causes a lot of irregular bleeding, amenorrhea, but it has a quick return to fertility. Not like the injection, this has a quick return to fertility. That's an advantage. Now, very important and where questions come from are this. तो ये दिख रहा है इस पे कोई copper नहीं है. That's how you identified it's completely white, no copper anywhere. Okay. So this is a levonorgestrel. It contains 52 milligram of levonorgestrel. It can be kept for 8 years is the lifespan. पहले 5 years था, but अब the company has said you can keep it for 8 years. This was in a new thing which happened in 2023. Okay. What else does it say? It says that most women, 80% of women will have amenorrhea at the end of 1 year. So it basically dries up the endometrium completely and it's locally acting. It's inside the uterus. Isliye the systemic side effects are less and it causes endometrial atrophy. Now, because of the endometrial atrophy, it is used in other conditions like heavy menstrual bleeding or menorrhagia जहाँ पे है, it's a good option to give, or fibroids that are not distorting the cavity, because अगर distorting the cavity है तो हम नहीं डाल सकते. We just discussed the contraindications to IUDs. You can't put it if you have a submucosal fibroid or a large fibroid like this. So there should not be any distortion to cavity. Then adenomyosis, then endometrial hyperplasia, then endometriosis. So these are the ones you have to remember where you can put it. जहाँ पे आप चाहते हो कि endometrium dry up हो जाए, atrophy हो जाए, you will give the Mirena. Contraindications to Mirena, same. You can't get pregnant if you have a IUCD. Suspected pregnancy, infection, undiagnosed vaginal bleeding, malignancies, कौन से cervical, endometrial, choriocarcinoma, and distorted cavity, Mullerian anomaly or a large fibroid or a submucosal fibroid. ठीक है. लार्क पे क्वेश्चन आता है, क्या होता है लार्क? लॉन्ग एक्टिंग रिवर्सिबल कॉन्ट्रासेप्टिव, मतलब जिसका फ्रीक्वेंसी ऑफ यूज 1 month से ज्यादा है. इसमें क्या क्या आता है? 3 आईज. व्हाट आर द 3 आईज? इंजेक्शन मतलब अंतरा. Implant. Implant matlab Norplant, yeah, these ones. Okay. And third eye is your intrauterine devices, both the copper T and the Mirena. So 3 eyes are LARC. LARC means long acting reversible. इसमें कौन से नहीं आते याद रखना. Your tubal ligation, sterilization don't come. Also, the vaginal ring doesn't come because vaginal ring lasts for 3 weeks, not for 1 month. Okay, so rings don't come and tubal ligation don't come. Only the 3 eyes come: injectable, implant, and intrauterine devices. Then we have this. This is also Government of India wala. ये क्या है? ये है. It's now called Chaya. पहले available था by the name Saheli. Okay. And this is, or it contains a selective estrogen receptor modulator. कौन सा वाला? Orniloxifin. Remember, SPRM दो टाइप्स के. SPRM सेलेक्टिव प्रोजेस्ट्रॉन रिसेप्टर मॉड्यूलेटर दो ही है. एक है मिफिप्रिस्टोन जो हम अबॉर्शंस में यूज करते हैं, और दूसरा है यूलिप्रिस्टल एसिटेट. यूलिप्रिस्टल हम कहाँ यूज करेंगे? इन इमरजेंसी कॉन्ट्रासेप्शन, ऑल्सो इन फाइब्रॉइड्स. रिमेंबर, पर अब ज्यादा यूज नहीं करते बिकॉज इट इज हेपेटोटॉक्सिक, इट कॉजेज लिवर टॉक्सिसिटी. So it's now less commonly used in fibroids, but majority of its use is as an emergency contraceptive. SERMs कौन से हैं? अभी तक हमने क्या क्या पढ़ा? SERMs में हमने पढ़ा क्या क्या पढ़ा? We have orniloxifin, we have tamoxifen, we have raloxifin, which is used in the menopausal age group as HRT. Okay, and even letrozole is a type of SERM. Okay, which we use for ovulation induction, but it has more of anti-estrogenic activity. Okay, so SERM is orniloxifin. It's manufactured by the Central Drug Research Institute in Lucknow. So it's a made in India thing. That's why it's very important, especially as an FMG. They want you to know कि India में क्या क्या बनता है. So what you do is here you give this once a week for 3 months. No, it's true. They want to know कि that's what they want to encourage, which is also a good thing. That बाहर का देख लिया, अब इंडिया का भी देखो, है ना, and get familiar with what's done here. So once a week for 3 months, and then twice a week till whenever she wants the contraception to be used. ठीक है, very important to remember contraindications. One is breast cancer. ठीक है, and the other important one is PCOS. एक और याद कर सकते हो, liver disease. ठीक है, remember liver disease उसमें भी add करो please. I forgot to add in contraindications of OC pill, वहां पे भी liver disease add करो. ठीक है, so यहाँ पे breast cancer, PCOS, liver disease, it is contraindicated. Okay. आई थिंक दिस इज द लास्ट टॉपिक, इमरजेंसी कॉन्ट्रसेप्शन. इस पे भी बहुत कंफ्यूजन होता है सबको. यूजपेज रेजिम क्या है? यूजपेज रेजिम, रिमेंबर यू आर गिविंग 100 माइक्रोग्राम ऑफ एन ओस ऑफ इथेनाइल ईस्ट्राडियोल. ठीक है, अब जो हमारे नॉर्मल हमारे नॉर्मल कॉन्ट्रास ओसी पिल्स होते हैं, ठीक है, उनमें कितना ईस्ट्रोजन होता है? इट्स 30 माइक्रोग्राम ऑफ इथेनाइल ईस्ट्राडियोल प्लस प्रोजेस्टेरोन, है ना. तो हमें इसको 100 बनाना है. तो हाउ मेनी टैबलेट्स वी हैव टू गिव? 3 to 4. सो वी गिव द अपर लिमिट. वी गिव 4 टैबलेट्स of our regular OC pill containing 30 microgram and repeat it after 12 hours. तो 4 टैबलेट दो, फिर 12 घंटे बाद 4 टैबलेट और देना है. ठीक है, बट if you're using the Purana wala OC pill, when Newspaper first described this, he described it with 50, उसके जमाने में 50 माइक्रोग्राम वाला OCP मिलता था. ठीक है, 50 माइक्रोग्राम इथेनॉल ईस्ट्राडियोल. तो तब 2 tablets. So he described it as 2 tablets of 50 microgram ethinyl estradiol containing OC pill and repeat those 2 tablets after 12 hours. But now we have low dose estrogen. So we have to give 4 tablets plus 4 tablets. Okay, I hope this is clear. And up to 72 hours of unprotected intercourse. Okay, but it is not used now, this method, because such a high dose of OC pill causes a lot of vomiting. Okay, so usually if you're giving this, you have to give an antiemetic also. Okay, and then you give this. Okay, the most commonly used one in India is LNG. This is available by the government as Easy Pill, EZY, Easy Pill. Okay, single dose of 1.5 milligram within 72 hours of unprotected intercourse is the drug of choice for the Indian population because हमारे यहाँ ulipristal acetate नहीं available है. ठीक है, so remember this is the drug of choice in India for emergency contraception, especially if the woman comes within 72 hours. It is more effective than Uspez. And it is more easy to tolerate because it's a single tablet. Ulipristal acetate is the most effective drug overall. Most effective hormonal. Let me write this clearly. Kal YouTube पे comment था. I felt very bad. My handwriting is bad. Most effective hormonal. इसलिए today I'm trying to write a little better. Most effective hormonal contraceptive overall is ulipristal acetate. ठीक है? So ulipristal acetate is given as a single tablet of 30 milligram within 5 days. So you can give it till a longer time, that is 120 hours. ठीक है, and 30 milligram is the dose, single dose. Okay, and lastly we've discussed this copper T. So overall most effective is actually the copper T, but if you're talking about hormonal, this is most effective. And this can also be given till 120 hours. So if your question, your clinical scenario says the woman is also looking for a prolonged method of contraception, then your answer will be this. Or if she has one child, she's married, has one child, is looking for a prolonged method, then you should always go for an intrauterine copper device. Okay, I thought that was the last topic, but I think instruments bhi hai. Let's see. So what is this? Easy. We will just go on identifying an important points. This is a Cusco's self-retaining speculum. Okay, now Cusco's ka advantage, it is self-retaining. That means I put it, this is a lock. I lock it and my hands are free. So now I can take a pap smear, I can pull out a copper T. Okay, these are the advantages. I don't need assistance. But the disadvantage is that ये space बहुत limited है. The circle is very small. So I can only put one instrument through it. I can't put two instruments. So it limits my access to the cervix and it also obscures the vaginal wall significantly. So it has the advantage of self-retaining. The disadvantage is it limits access, okay, and it is also obscuring the vagina. The vagina पे कोई lesion होगा तो I can miss it. This is the SIM speculum. This is always used with this instrument. So this is the SIM speculum. And it is always used with an anterior vaginal wall retractor. ये curate नहीं है, curate बहुत छोटा होता है, ये बहुत बड़ा होता है. So this is an anterior vaginal wall retractor used with some speculum. So this I put in the posterior vaginal wall and I lift the anterior vaginal wall with this instrument. So एक instrument से I'm holding the speculum, दूसरे से the retractor. So I'm able to see the cervix. But both my hands are now occupied. So I have to call my assistant to come and take the pap smear or do the procedure. Okay, because both my hands are now occupied. So this is the disadvantage. Disadvantage is you need help. Advantage, but is very good because it has so much space, lot of space, and you can do a lot of procedures. Okay, so Cusco's is more for visualization, but you can take a pap, so you can visualize the cervix, you can take a pap smear, you can remove an IUD because intrauterine device को सिर्फ thread खींचना है, artery forceps लेके खींचो. You can do a colposcopy because again that is just visualization or taking a biopsy. That's all you can do. Biopsy ले सकते हो बस. अगर हमें DNC करना है या suction evacuation करना है या hysteroscopy करना है, then we have to use a SIM speculum. Okay. What is this? This is a uterine sound. It is used to sound the uterus. Sound the uterus means measure the uterocervical length before doing a procedure so that you know कि इतना length है, 6 centimeters है या 7 centimeters है. This has gradations. So you don't inadvertently perforate the uterus when doing, say, a suction evacuation or doing a DNC. Okay, also remember it is not usually used in a pregnant uterus. So MTP में नहीं use करना है इसको because it's a very thin instrument. You can perforate the pregnant uterus. It's used in DNCs mainly, endometrial biopsies, DNCs. These are Hagar's dilators. They are mechanical dilators of the cervix. So cervix को जब हमें dilate करना है, cervix remember is a closed structure. To do a DNE, to do a DNC, you have to open it up. So you can open it up either pharmacologically, using which drug? Prostaglandin E1, misoprostol. Or you can do it mechanically using these dilators, Hagar's dilators. So it starts with 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeter. So it goes on till usually the largest one is 12 millimeter. उससे ज़्यादा भी आते हैं, but commonly 12 or 14 millimeter is usually the largest size. What is this? If you see a curved instrument with a lock, this is not clear, but this has teeth at the end. This is a valsalum. This is used to hold the anterior lip of cervix. Okay, when you're doing a procedure on the cervix, like say a DNC or a hysteroscopy or a vaginal hysterectomy. So holding the cervix is done by a valsalum. or a tenaculum. This is a substitute of a valsalum, but it is more traumatic because can you see how sharp one tooth, but very, very sharp. So it is never used to hold a pregnant uterus. Both of them are used only to hold a gynae uterus. That means a non-pregnant uterus. What is this? This is an ovum forceps. Typical feature एक तो ये egg shaped ends होते हैं और देखो यहाँ पे no lock. So very typically there is no lock here. Okay, this is to avoid trauma to the uterus and it is used for evacuation of products when you're doing a dilatation and evacuation. Okay, like in incomplete abortion or inevitable abortion, when you have something left behind, you just use this ovum forceps to take it out. This is the uterine curette. This is used to curette the walls of the uterus. You have a blunt end, जो हम obstetric procedures में use करते हैं, like following a dilatation and evacuation, and you have a sharp end which you use in a gynae uterus, like if you're doing a DNC, if you're taking an endometrial biopsy, you do a DNC and this is what you use. Okay. This is a manual vacuum aspirator and these are the color coded plastic Carman's cannula. Okay. So this is done when you're doing an MTP or when you're doing a suction evacuation in a molar pregnancy or an incomplete or inevitable abortion. So pregnant uterus में जब आप products निकाल रहे हो, तो you can use this. This syringe का volume ये question आया हुआ है 60 ml. It is a 60 ml syringe. These cannulas are according to size. Okay, and these are valves here. If you press the valves, the suction gets created. Okay, and if you release the valves, the suction gets released. So you attach this part here and you put this inside the uterus. And then when you release the valve, all the products come inside the syringe. What is this? This we've discussed. This is an Ayer's spatula used to take a pap smear. Okay. This, I don't know what it was supposed to be. I don't know. Okay, this is a punch biopsy forceps. We've done this. This is a sponge holder or a ring forceps. This is also in surgery. It is used to, apart from surgical things, it is used to hold. तो मैंने बोला valsalum tenaculum से we don't hold the cervix, okay, because of in a pregnant uterus because it's traumatic. So holding the cervix of a pregnant uterus is usually done by a sponge holding forceps. Okay, because it is atraumatic. It doesn't have teeth. Okay, what is this? This is a Babcock forceps. Babcock कहाँ use करते हैं? To hold delicate structures. और gynae में कौन सा delicate structure है? The fallopian tube. So if you're doing a tubal ligation or you're doing a tubal recanalization, you will use this instrument. Okay, how do we do a tubal ligation? Government of India का recommended technique है modified Pomeroy's technique. कहाँ करते हैं? At the isthmic portion of the fallopian tube. How is it done? We create a loop, okay, of the fallopian tube of 1.5 to 2 centimeters. Then we put a suture of catgut, okay, and then we cut off this part. Okay, so this is modified Pomeroy's technique of tubal ligation, what is recommended by the government of India. What is this? So I was talking about myomectomy. तो जब हम laparotomy करते हैं, laparotomy, we use this instrument to hold on to give traction to the fibroid, है ना? So this is called a myoma screw. Okay. What is this? This is also used in fibroids. It is when doing a myomectomy. So remember, myomectomy, abdominal myomectomy, matlab laparotomy and myomectomy is a very bloody surgery. It's very, very vascular. So it leads to a lot of blood loss. So how do you reduce the blood loss? One way is using this instrument. This is called a Bonney's myomectomy clamp. तो ये यूट्रस है, ठीक है। सपोज यहाँ पे फाइब्रॉइड है, सपोज इस फाइब्रॉइड को निकाल रहे हो, ठीक है। सो बिफोर यू स्टार्ट द सर्जरी यू पुट दिस क्लैम्प एंड दिस क्लैम्प इज पुट एट दिस लेवल, ठीक है। ये कौन सा लेवल है? दिस इज एट द लेवल ऑफ द इस्थमस। इस्थमस मतलब यूट्रस बॉडी और सर्विक्स का जंक्शन। वहां पे क्या इंपॉर्टेंट स्ट्रक्चर है? द यूट्राइन आर्टरीज हियर, ओके। सो यू आर बेसिकली occluding the blood supply of the uterus, and you try to do the myomectomy while the clamp is put. So we put the clamp for 20 minutes. In that 20 minutes, you try to do the surgery. After 20 minutes, release the clamp. नहीं तो क्या हो जाएगा? Uterus will get ischemic. Release the clamp. Then again, let blood go for some time. Then again, put the clamp. So this is the Bonnie's myomectomy clamp. If you don't have the clamp, you can even just tie a Foley's catheter or a red rubber catheter around this area, okay, for 20 minutes and then release. This will temporarily stop the blood flow to the uterus, and in that time you quickly remove the fibroid. What is this? This comes as a question very many times. This is the Leach Wilkinson cannula. Okay, it's also called the HSG cannula because HSG में use करते हैं. We also use it in laparoscopic chromotubation. तो basically जब हमें, both of these are tests for tubal patency. So whenever we want to check the tubal patency in infertility, okay, we are basically going to put this instrument and inject dye from here. In HSG, we instill a radio opaque dye ताकि वो X-ray पे दिख जाए. In laparoscopic chromotubation, we instill methylene blue dye and then laparoscope से हम देखते हैं कि वो blue dye बाहर आ रहा है या नहीं. Okay, so this is just an instrument to put the dye inside the uterus. Okay, either on HSG or laparoscopic chromotubation. Again, a question asked so many times. I think every paper I open, I see this instrument. This is the Verries needle used in laparoscopy. So surgery में भी पढ़ा होगा. What is it done? It is used to create pneumoperitoneum. So when we do a laparoscopy, we are instilling gas. Which gas? Carbon dioxide in the peritoneal cavity, and then we are able to see inside. And we instill the gas through this Verries needle. Hysteroscopy में क्या करते हैं? हिस्ट्रोस्कोपी में हम यूट्रस को कैसे डिस्टेंड करते हैं? what is the thing we put inside? We put in fluid in the inside of the uterus so that we are able to see inside. And what fluid do we commonly put? We either put normal saline or we can use glycine or mannitol. Okay, but for laparoscopy we put in carbon dioxide. Now, these are the last slides. I think ना मुझे लगा I should end it with these two things because आप लोग इसमें काफी confuse हो जाते हो और इन पे questions आता है. ये करके we will end today's class. Okay. So surgeries for prolapse. Prolapse मतलब uterovaginal prolapse. Now, most patients who come with prolapse are of the age group in the post-menopausal age group because the most common cause for prolapse of the uterus is estrogen deficiency, which happens in the menopause. So the supports of the uterus get weak and the prolapse comes out. Okay. Now that is one age group. The other age group is something called nulliparous prolapse. These are those young girls who have congenital weakness of the muscles and the fascia, and before they are married, before they even have children, you have these girls coming to us with nulliparous prolapse. It's rare, but they do come. Okay. And the third category is young women with family complete, okay, with prolapse. But they are young, they are in the age group of 30 to 40. Okay. So इस age group में क्या करोगे? इस एज ग्रुप में क्या करोगे? इस एज ग्रुप में क्या करोगे? So this is one is depending on the age. So surgery depends, number one, on the age. Okay. Second, it also depends on the type of prolapse. So when we talk about prolapse, usually the main type is the uterus has come out. So it's called a uterine prolapse or a uterovaginal prolapse. But many times the bladder also comes down, which is called a cystocele. That means the anterior vaginal wall comes down. If the anterior vaginal wall comes down, that basically means the bladder has come out. It's called a cystocele. And this third type is the rectum has come out through the posterior vaginal wall. So the posterior vaginal wall has prolapsed, or posterior vaginal wall ke piche kya? The rectum. So the rectum comes into the vagina and may come outside. So this is called a rectocele. So your treatment depends on number one, which age group you're dealing with. Number two, what type of prolapse you're dealing with. Okay. So let's start. I'm talking about surgical management, okay? Because surgeries kya use karte ho for different prolapses, you should know. So let's talk about the post-menopausal age group. Now, usually all three occur together. It's very rare to have only a cystocele and nothing else. Some amount of descent is there in a woman who in this age group who has prolapse. Some amount of descent is there in all parts of the vagina. It is not necessarily a cystocele only or a rectocele. So if all three are there, matlab uterus plus cystocele plus rectocele, what will you do? You will do a vaginal hysterectomy with a cystocele repair. Cystocele repair को कहते हैं anterior colporrhaphy, because anterior vaginal wall है, anterior colpo मतलब vagina, raphy मतलब repair, ठीक है, with a posterior colpo perineorrhaphy or simply a posterior colporrhaphy. पेरिनियोरफी इसलिए कहते हैं बिकॉज यूजली उस एरिया का पेरिनियम भी डिफिशिएंट होता है, सो वी रिपेयर दैट पार्ट ऑल्सो. So vaginal hysterectomy with anterior colporrhaphy with posterior colpoperineorrhaphy, and this entire surgery is called as Ward Mayo's repair. ठीक है. Now suppose आपके क्वेश्चन में आता है only cystocele, फिर क्या करोगे? Anterior colporrhaphy. Question comes only uterine prolapse, you will do a vaginal hysterectomy. Only rectocele, you will do a posterior colporrhaphy or a posterior colpoperineorrhaphy. So this is in this age group. Okay, I hope I'm clear. Just give me a thumbs up. All right, all right, all right. Okay, now let's come to the second category. Second category is nulliparous prolapse. Nulliparous matlab you can't remove the uterus. They have not had children yet. You want to conserve the uterus. Nor can you cut a part of the uterus. वो इसमें irrelevant है, इसलिए मैं बोल रही हूँ. You can't even cut a part. You have to retain the whole uterus. Okay, so what will you do in this group? In this age group, you're going to do what are called as hysteropexies. Okay, there are many types of hysteropexies, including sling surgeries. That means आप uterus को किसी टेप से या किसी उससे आप किसी structure से you are hanging the uterus. Okay, hystero means uterus, pexy means you are fixing it to some point. Okay, so nowadays we don't do sling surgeries that commonly, but older days they used to do the different sling surgeries. So you have Shirodkar's sling, you have Purandare sling, you have Khanna sling, you have Vidkut sling. These are all named after very famous Indian surgeons because the sling surgeries were developed primarily by Indians. Okay, so all these sling surgeries are basically taking some suture material or some tape and hanging the uterus, usually by the cervix. That's why they're also called as cervicopexies. Cervix को किसी sacrum से टंगा दिया या anterior superior ilex spine से टंगा दिया. So those are sling surgeries. Nowadays we do a lot of laparoscopic sacrohysteropexies. What is this? You're basically stitching the cervix, or not stitching, actually we put a mesh or a suture material from the sacrum till the cervix is usually the part of the uterus we hang. So these are sacrohysteropexies or sacrocolpopexies sorry, sacrocervicopexis, not colpo, sacrocervicopexis. So any hystropexy or cervicopexy or sling surgery, if you see this term, okay, any of the slings or any sacrohystropexy or cervicopexy, that means cervix ko you are hanging. This is done in nulliparous women. Okay. And the third group, the young woman whose family is complete, she doesn't want children. Say your question comes 30-year-old para 2 living to with family complete comes with prolapse. This is usually because of deliveries which have been done by untrained people, premature bearing down, and that has led to weakness of the muscles and descent of the uterus. So in the third group, that means young women with family complete, you don't want to take out the uterus. That will be too drastic. What will you do? Here you can do the Manchester repair और Fothergill's surgery. ठीक है, इसमें क्या कहते, इस इन टाइप ऑफ सर्जरीज में क्या करते हैं? We do what is called as cervical amputation. That means we cut a bit of the cervix, especially the part coming outside. ठीक है, and along with that we strengthen or we do what is called a Mackenrod. Mackenrod क्या होता है? It is the cardinal ligament. Mackenrod ligament plication. That means जो बचा हुआ cervix का part है उसको हम Mackenrod ligament, that is the cardinal ligament, we stitch the cardinal ligaments onto the amputated portion of the cervix. So we do a Mackenrod ligament plication. We can even bring the uterosacral ligaments. Basically, the side ligaments को हम cervix के पास ले आते हैं, and that pushes the uterus up. Okay, so this is what is done. Plus, you can also do along with this a cystocele or a rectocele repair separately. Basically, you're not removing the uterus. You're cutting the cervix and you're pushing the cervix up by plicating or bringing together. Plication ka matlab bringing together the cardinal ligaments over the cut surface of the cervix. Okay, so this is what is done if it's a young woman with family complete. ठीक है, तो अब इसमें I hope confusion has gone. Which surgery you will do for what group? Now there's a third group or fourth group of patient जो आते हैं walled prolapse के साथ. वॉल्ड प्रोलैप्स का मतलब क्या है कि जो जिनका हिस्टेक्टमी हो चुका है. सो पोस्ट हिस्टेक्टमी, से अ वुमन अंडरवेंट हिस्टेक्टमी 10 years back and now she's come with a mass per vagina. When I examine her, I see the vagina is outside. तो usually ये क्या होते हैं? Usually these are cystoceles because the bladder is there, or rectoceles, and very commonly they are also enterocele. Enterocele क्या होता है? The small intestine has prolapsed through the vagina and it is coming out. What will you do for walled prolapse? Remember two surgeries. The surgery, the gold standard, but that's the best surgery, is a sacrocolpopexy. मतलब colpo मतलब vagina, you are fixing the vagina to the sacrum. Okay. But you can also do a sacrospinous ligament fixation. That means this is a vaginal surgery. This is an abdominal surgery. मतलब आप vagina को, colpos को, you are fixing to the sacrospinous ligament. This is a vaginal procedure, or you are fixing the vagina to the sacrum. So if you see these two terms, sacrocolpopexy, sacrospinous ligament fixation, these are for walled prolapse, not for uterine prolapse. Okay, so these are all the surgeries that you do for prolapses. Okay, just a quick revision. Postmenopausal age group, you will basically, most of the times you will have to do a vaginal hysterectomy with a cystocele repair, which is called an anterior colporrhaphy, with a rectocele repair, which is called a posterior colpopenenorrhaphy, and all three are called the Ward-Mayer's repair. If she's a young nulliparous, never had a never had kids, you will want to save the uterus. So you will do a sling surgery, what are called nowadays as hystropexes or cervicopexies. तो हिस्ट्रो जहाँ वर्ड आ रहा है मतलब यूट्रस को आप बचा रहे हो, पेक्सी मतलब यू आर हैंगिंग इट, और द स्लिंग सर्जरीज, पुराने जमाने में इनको हम स्लिंग सर्जरीज कहते थे. Young woman with family complete, you can afford to cut off the cervix. Okay, and these are called as Manchester or Fothergill surgery. Cervical amputation with plication of the cardinal ligament with a cystocele or rectocele repair. And vault prolapse, that means post hysterectomy, the prolapse has happened. You are going to do a sacrocolpopexy or a sacrospinous ligament fixation. Now, last topic, genitourinary fistulas. Now, इनका क्या मतलब है? A fistula between the urinary tract and the vagina or the uterus or some structure there. Okay. Now, the commonly asked question, which I'm just going to discuss, is this 3 swab test. Now, before this, the most common cause of the most common, or let's do this, the most common obstetric cause of a genitourinary fistula is obstructed labor. Okay, and this commonly causes a vesico-vaginal fistula. So what is happening in obstructed labor is that the fetal head is jammed against the pelvis for a very, very long time. उससे क्या हो रहा है? उससे क्या हो रहा है? Bladder gets necrosed. One part of the bladder gets ischemic because of the head being pressed there for hours and hours and hours. So what happens if once the baby is out by cesarean, you've sutured everything up, that necrosed area gets pura ischemic hoke, pura necrose hoke, it forms a fistulous tract with the vagina. So post in very backward countries, even especially in African countries, you still see very commonly VVF post obstructed labor, where women reach the hospitals very, very late for a cesarean section. Okay. And the most common gynae cause for a genitourinary fistula is post hysterectomy. You've done a hysterectomy and you have injured the ureter or the bladder or the urethra. Okay, so these two are important to understand the causes. Now, if it is post obstructed labor VVF है तो इसमें तो uterus होगा है ना. So what we do here is we do a VVF repair. Okay, and this is all you need to do. You don't have to know the details. What is the best investigation? The best investigation for a genitourinary fistula is a CT urography. Remember this. Okay. But you should also know how to clinically diagnose a fistula. So that's why you should know the 3 swab test. Now, the 3 swab test is done in women who have come with this wala fistula. Post hysterectomy, they've come to you and they've come with continuous leaking. Now, once they come to with continuous leaking, you know that there is a fistula somewhere, especially if she's undergone a hysterectomy. So here is the bladder. Okay. Here is the vagina, which is now without a uterus because she's post hysterectomy. Okay. Here is the ureter somewhere. Okay. Your job in the clinic, in your OPD, is to try and determine कि fistula kahan pe hai. You will of course do a CT urography. This will confirm your fistula, but if you don't have the facility or in the OPD, you can get a rough idea. Okay, because the fistula can be here. This is a ureterovaginal fistula. It can be here. This is a vesicovaginal fistula. And it can be here. This is a ureterovaginal fistula. Okay. So how do we know where the fistula is? We put 3 swabs inside the vagina in the OPD. Dry cotton swabs डालो और यहाँ पे एक Foley's catheter डालो and fill the bladder with methylene blue dye. And then ask the patient to lie down and after 10 minutes, take out the swabs. Now, if the lowermost swab is stained with blue dye, ठीक है, और बाकी ऊपर दोनों blue नहीं है, then this is a ureterovaginal fistula. If the middle one is stained blue, okay, then it is a vesicovaginal fistula. And if the last one, सबसे ऊपर वाला stained है, wet है but unstained है, unstained but wet because of urine, it is a ureterovaginal fistula because the dye is not in the ureter, it's only in the bladder and the urethra. So it's a ureterovaginal fistula. This is clinical in the OPD, and this question is commonly asked, where is the fistula based on the 3 swab test. Okay. So this is the end of today's class, and I think I've covered the most important topics. I may have missed a few, but that's because they would be pretty easy or straightforward. I've tried to cover most of the previous year topics, and I wish all of you the very, very best. Once you've done your exam, please read Atul Gavande's books on medicine. He's a doctor, he's a surgeon in the US, and he has written 2 books, Better and Complication. I hope you're reading this, what's written here. Okay. So his books are very nice, very inspiring for all of us, and I hope to speak to most of you, all of you, very, very soon. So best of luck for the exam. Do well. Gynae में नहीं डरना है, overthink नहीं करना. Questions are very straightforward, very simple. Even clinical questions, think of common things first. Okay, and options देखने से पहले clinical questions में especially पहले सोच लो क्या आंसर होना चाहिए. Once you see the options, you start getting confused. Okay, so that's what I would advise to you. And thank you very much. Any doubts, again, you can message me, and I'll try to answer all your queries as soon as possible. Okay, thank you. Good night. Good night. Sorry, I'm not reading the chat box. Just message me separately. Okay, thanks. Good night. Good luck.